Hello, everyone. Welcome, and thank you all for joining us from across Canada and from 10 other countries around the world. Out of our deep respect for Indigenous peoples in Canada, we acknowledge that the Canadian Premature Babies Foundation is situated upon traditional territories of the Anishinaabe and Haudenosaunee Confederacy and the Wendat peoples. We also acknowledge the land covered by Treaty 13 is held by the Mississaugas of the Credit First Nation. We also recognize the contributions and enduring presence of all First Nations, Métis, and Inuit peoples in Ontario and the rest of Canada. We are grateful to work on this land. My name is Fabiana Bacchini. I am the Executive Director of the Canadian Premature Babies Foundation, CPBF, and the mother of a surviving twin born at 26 weeks. Thanks to the support of bedside nurses and a team of lactation consultants, I had a very successful lactation journey in the ICU and during the transition home. I was able to breastfeed my son for 2 years. And for a couple of years now, families have been sharing with us that they don't always feel supported and sometimes feel rushed to bottle feed or formula feed to be able to have their babies discharged sooner. The pandemic has added another layer of difficulties for families with restrictions in the hospitals and less support in many communities. We all know that there is no lack of evidence on the benefits of human milk for all babies, in particular to our population. And therefore, CPBF has organized this workshop in collaboration with Canadian Neonatal Network, the Canadian Preterm Birth Network, and the Canadian Association of Neonatal Nurses. This week is Canadian Breastfeeding Awareness Week, and we want to make sure every parent feels supported and educated on the importance of human milk for their babies. I want to acknowledge the difficult time that healthcare professionals are facing during the pandemic and acknowledge your continued commitment to families and the work that you all do. And on behalf of all our families, thank you for being here today and taking the time to learn and share your experiences. I want to thank our sponsors, Medela Canada and Prolacta Bioscience, for supporting our educational programs. We want you to participate. Please send your questions, your comments, and share your experiences. We are going to do a live Q&A at the end of each session, so we do want you to interact with us. And at the end of this workshop, we will automatically receive a certificate of attendance and a separate email with a survey. Please do fill out the survey. We are constantly seeking ways to improve our programs, and your feedback is vital to this process. So without further ado, I would like to introduce you to my co-host and creator of this workshop, Dr. Rebecca Hoban, neonatologist and director of breastfeeding medicine at the Hospital for Sick Children and associate professor at the University of Toronto. She has been a great supporter of our work here at CPBF, and we are grateful to have her here today. Dr. Hoban, welcome.
Thank you, Fabiana, and hello to everyone joining us. So I want first just to thank Fabiana and the Canadian Premature Babies Foundation for organizing this. I think I speak for everyone who's going to be talking today that we're really excited for this opportunity for outreach to the community. And it sounds like community in this case means not only Ontario, but Canada and many other countries around the world. So that's really exciting that we're able to do this today. And again, thank you for taking the time out of your busy day to hopefully learn some really practical tips that'll help your patients. So we organized this workshop based on common questions that we get a lot in hospital, both at sick kids, but from our referring hospitals as well. And we're really going to focus on common problems as well as opportunities for improvement that we see a lot. And this is true whether you're a level 1 hospital or a clinic or a high-level perinatal center. There's always opportunities for improvement. We really wanted to share up-to-date evidence-based practices that can help your families meet their lactation goals, whatever those may be. We know exclusive breastfeeding isn't always possible for everyone. And so however much breast milk we can get for babies, we know every little bit is important. This workshop is really geared towards parents who deliver at-risk infants, but that is really a broad spectrum. For us at sick kids, that's often our very, very tiny babies with prenatal surgical diagnoses or medical complexity. But at-risk babies can also be your late preterm baby, your infants of diabetic mothers, or those babies who simply are having some problems latching. And it's really important, I think, for especially for those moms who didn't expect to have lactation problems or didn't expect to have some pump dependency early on, that we're able to support them quickly, which will again help them meet their lactation goals. And then just to close this portion as well, I do want to point out that in a lot of our talks, we do use the terms mother or mother's own milk. Um, these are used in the medical literature, but I do definitely we recognize that not all lactating parents identify as mothers, and not everyone uses the term breastfeeding as well. So please, when you're working with your own patients, please substitute the appropriate words that work for your patient population. So without further ado, I will turn it back to Fabiana, and again, excited to host everyone for the next couple hours. Please, as Fabiana pointed out, please put questions into the Q&A portion, and we will take breaks after each session to answer those and have some hopefully good discussion.
Thank you, Dr. Hoban. I'm very excited about the agenda for today, and we're going to start our first presentation with Dr. Bilal Al-Sheikh. He is in Calgary on the benefits of human milk. Dr. Al-Sheikh is currently a clinical associate professor at the University of Calgary and medical director of the NICU at South Health Campus in Calgary. Dr. Al-Sheikh co-chairs the Canadian Neonatal Gut Health of EPIC and is a founder of the Society of the Neonatal Nutrition, Gut, and Growth. Dr. Al-Sheikh, thank you so much for joining us here today.
Hello, everyone, and thank you for joining my presentation. Today, I'm going to talk about the benefits and the rates of breast milk feeding. I will focus largely on preterm infants. I have two objectives. First one is to briefly describe the benefits of breast milk feeding on infant health and on mother's health. And second, to describe the rates of breast milk feeding in very preterm infants in Canada, and I also would like to benchmark our rates with other countries. Benefits of breast milk feeding. Before going there, I just want to emphasize on that when we say breast milk feeding, we mean either breastfeeding, which is direct nursing, or pumping, then feeding via a tube or a bottle. There are many benefits of breastfeeding on mothers and also infants' health. Starting with infant health benefits, the proven benefits from large studies and also systematic reviews include the lower risk of infections, particularly acute middle ear infection and gastroenteritis, lower risk of sudden infant death syndrome, asthma, type 1 diabetes, adult obesity, and necrotizing enterocolitis, which one of the most devastating diseases in preterm infants. There are also potential benefits that shown in some of the studies, which include higher IQ scores, particularly for preterm infants, lower risk for atopic dermatitis, chronic digestive diseases, and acute leukemia, and some improvement in cardiovascular health of preterm infants. Benefits associated with moms who breastfeed include reduced risk of breast cancer, reduced risk of ovarian cancer, reduced risk of high blood pressure, as well as reduced risk of type 2 diabetes. There are also potential benefits like decreased postpartum bleeding and depression and lower cost for the family. Rates of breast milk feeding in preterm infants. We'll start with the Canadian experience. Here I'm going to talk first on all newborn infants. The breastfeeding initiation rates in Canada have increased from less than 25% in the 1960s to 90% in 2015. However, there are almost 25% of women stop breastfeeding before their infant is 1 month old. And the most common reasons mothers give for stopping breastfeeding before 6 months include not enough milk and difficulty with breastfeeding technique. These factors could be mitigated by education and support of the mothers. Of interest, breastfeeding rates also vary across Canada from west to east. In 2011-2012, for example, breastfeeding initiation ranged from 96% in British Columbia and Yukon to 57% in Newfoundland and Labrador. We'll move now to preterm infants. This is a study that we recently published on behalf of the Canadian Neonatal Network and the Preterm Birth Network in Canada. The study included almost 6,404 infants born less than 33 weeks gestation between 2015 and 2018. Here is the association between the rate of breast milk feeding at discharge and the site of birth. Here you see all the NICUs in Canada. Those are part of the CNN, the Canadian Neonatal Network, and each column represents one of these NICUs. The rate of breast milk feeding at discharge ranged between 49% here to almost 87% on the other end. The mean for breast milk feeding was around 70%. These NICUs, I think they can improve their rate of breast milk feeding at discharge, and we should always aim at the higher rate, at least 85 to 90%. We also looked at the factors that could associate with a lower or a higher rate of breast milk feeding at discharge. Maternal diabetes and maternal cigarette smoking reduces the odds of breast milk feeding at discharge. These factors are well known in literature. On the other hand, use of any mother's own milk by day 3 of life was among the positive predictors for breast milk feeding at discharge. The odd increased by almost 3 times. Other factors, on the left graph here, we see the association between the rate of breast milk feeding at discharge and the number of children for the mother. So primary mothers are more likely to breastfeed their babies, or at least to have their baby using their breast milk at discharge. And every additional child, there is decrease almost by 5%. On the right graph, we see the association between the rate of breast milk feeding at discharge and gestational age group. Infants at younger gestational age were less likely to receive breast milk feeding at discharge. We see the lowest rate in those born between 22 to 25 weeks gestation. We concluded from this study that NICUs with lower rates of breast milk feeding may use QI measures to support early breast milk feeding, particularly for mothers of younger gestation infants, mothers with high parity, mothers who smoked cigarettes during pregnancy, and mothers diagnosed with diabetes. How we can use QI measures to improve breast milk feeding? Here is an example of a QI initiative from Calgary, which led by a QI nurse, Linda Kostaki, and a lactation consultant, Noreen Blashley. The aim or the main focus of this initiative was to educate mothers about the importance of breast milk feeding and to allow nurses to support mothers in the first 6 hours after delivery. The best practices utilized and shared with nurses include the early pumping, hands-on pumping routines, emphasis on the value of colostrum, and important protective effects of breast milk for preterm infants. On the left graph here, we see the trend of breast milk feeding at discharge from the start of the project or before, which is around 82%, then to the end of the project when we reported our outcome. There was almost a 9 to 10% increase in the rate of breast milk feeding at discharge using the measure we used in the we mentioned in the QI project. On the other hand, or on the right graph here, we see the change to the rate of necrotizing enterocolites. The incidence of necrotizing enterocolites dropped from around 9% to almost 5%. Benchmarking with other countries. We'll start with California. This is a study done using the California Perinatal Quality Care Collaborative for very low birth weight infants. The rate there of breast milk feeding at discharge was around 61%, but we see significant decline between birth and discharge, and then even after discharge. The conclusion from this study was that the support for mothers is needed throughout the first few months of life, whether the babies are in the NICU or discharged from the NICU. Using Swedish Neonatal Quality Registrar, and here I'm going to talk about the breastfeeding, the direct nursing. Why Sweden? Sweden is known to be actually a pro breastfeeding country with high breastfeeding rates and a beneficial parental financial support during infant hospitalization, which allows parents to stay with their babies. This graph showing the trend of exclusive breastfeeding and also like partial breastfeeding and no breastfeeding in those lines over the years between 2004 and 2013. The rate of exclusive breastfeeding dropped from 59% to almost 45%, and this was very alarming. The drop in the rate of breast milk feeding was noticed in all preterm subgroups: moderate preterm, very preterm, and extremely preterm infants. But the most significant decline was in extremely low birth weight infants or extremely preterm infants, which is the dotted the line here. The factors of not breastfeeding exclusively in very preterm infants in the study included year of birth, maternal mental illness, which increased from 1.5% in 2004 to 5% in 2013. Also, they found an increase in the rate of a small for gestational age infant. Moving to Europe, and here I'm going to talk about the breast milk feeding again. This study done in several parts of on several regions in Europe. It's called the APIS study. And on the graph here, we see the regions that they extrapolated the data from and the rate of breast milk feeding at discharge. The white columns here represent the exclusive breast milk feeding. The gray ones are the partial breast milk feeding. So these two combined represent the breast milk feeding, any breast milk feeding at discharge. The highest rate of exclusive breastfeeding or breast milk feeding was in Netherlands. The highest rate of any breast milk feeding, whether it's exclusive or partial, was in Denmark. There are some regions with very low rate actually of breast milk feeding. For example, the northern UK. The average rate of any breast milk feeding in this study was around 58%. So it's about 10% less than the average in Canada. And the positive predictors for any breast milk feeding was or were the first enteral feed less than 24 after birth or after birth, antenatal steroids, and primary. In conclusion, breast milk feeding is one of the most effective strategies to promote health and prevent diseases in all infants, including those born preterm. Rates of breast feeding and breast milk feeding vary widely between ICUs in Canada and also in the other countries we mentioned. There is a high potential for improving breast milk feeding through policies and QI initiatives. Thank you. And I am happy to take questions.
Dr. Sheikh, thank you so much for your presentation. Very enlightening. Certainly things that we know how important breast milk is. My question to you is, what is our target in Canada? And at this point, during the pandemic, we know all the restrictions that are happening and not as much education for families. Are we concerned with the rates?
Sorry, Fabiana, you are cutting out.
So my question was if...
thank you, Fabiana. That's a...
Yes, can you hear me now?
Yeah, that's better now, Fabiana. If you... Oh, yeah. Go ahead. Yeah, sorry. The internet seems to be unstable.
Yes, I asked you what are the ideal rates for Canada, and should we be concerned about the rates dropping during the pandemic with all the restrictions and not as much information for parents at this time?
Yeah, that's a great question, Fabiana. The rate in general was around 70% on average, but there is like a wide variation in the rate. During the pandemic locally, what we noticed that there is some drop in the rate, at least in the beginning of the lockdown, basically the first lockdown we went through. But after that, things went back to normal. I think part of this drop was related to the visitation like policies, and everyone is confused whether they are going to come back to the not like our average basically within like 1 month or 2 months. But the beginning was very hard. Now there's not much but there was lots of concern about it for sure.
So you talk about having more QI initiatives to improve the breastfeeding rates. What do we need to do to have those in place? Because it seems that we know the evidence, we know the benefits. Why we're still not there? Why do we need more quality improvement projects in different NICUs to have this up and going and support more families?
I think what we really need, we need like a full team to work on that. This like from nurses, from physicians, from lactation consultant. The priority of breast milk feeding should be the aim of everyone working in the hospital. Like from the mom when she comes to the to delivery until the baby is discharged. Everyone working with the mother or talking to the mother or supporting the mother should aim to emphasize on the importance of breast milk feeding for the baby and also for the mother.
Okay, I just want to remind the audience, if you have questions, please send on a Q&A rather than the chat. But I'm going to go through the Q&A now. Shirley, thank you for joining us. She said early pumping was mentioned as one of the teaching to support moms. How early should we introduce pumps in the postpartum period? I work in postpartum department. Great question. Thank you.
I think it should be introduced with
Dr.
2
Belau, you
hours.
are
The earlier
cutting
the
off.
better.
Can you
This
repeat
is
it?
for mothers like deliver preterm babies. The aim. Thank you for that question. Yeah, that's very important. Yeah. So the aim to start pumping within 1 to 2 hours from the birth of the baby. That's the ideal. Like once every done with the mom and mom like things settle down. Someone should speak with the mom and teach her if she doesn't have previous experience, like with the bumping with her. And this is largely like for preterm infants. There are some like mothers who may benefit to start of even hand on bumping, for example, even before birth. That means like for mothers. Especially for mothers with the diabetes or mother with diabetes. That might help for term babies. For preterm baby, we don't have the evidence to support that, and we are worried that any stimulation can probably like induce some preterm labor or exaggerated the preterm labors after birth.
Okay, Dr. Sheikh, your audio is really bad, it's cutting off. We have a few questions on the Q&A and a couple of comments on the chat. Would you mind answering them offline, and then we can go ahead with Dr. Hoban, so we don't miss your audio, because you know you have important things to say. Maybe you can just type the answer to our live audience. Thank you.
And some of those
Thank
questions
you,
too,
everyone.
some of the questions about early pumping specifically, and I can will be answered in the next couple talks, and I can also address the LC question as well, because I published on that as well. So,
thank you.
So stay tuned.
Welcome to my talk about human milk safety. I'm going to be doing a quick hits presentation about maternal medications as well as COVID-19 infection and vaccination. We're going to talk about the most common medications for which I get questions, and moms asking, can I breastfeed? Should I pump and dump? What do I do? We're also then going to transition to COVID-19 infection and vaccination and what to do with lactation. So big picture, very, very few medications or substances are a hard contraindication to lactation. Chemotherapy drugs are. Luckily, these aren't used very often in the postpartum population. Street drugs like cocaine. But even medications like lithium, which were traditionally taught as a contraindication, actually are no longer in term infants, for example, who can be followed closely. And I want to point out this website from the States, the NIH LactMed's website. If you Google LactMed, you'll find it. And you can look up really any drug, and it has really extensive and recent data that goes over the safety profile as well as infant levels when available and short and long-term outcomes. It's an excellent website and the one I use most commonly for these questions. Overall, our job as healthcare providers is to reassure families that the typical peripartum and postpartum medications that are prescribed to mothers are safe in lactation. These include medications like prescribed narcotics, antibiotics, meds for preeclampsia or hypertension, or medications for diabetes. And if there is any doubt, have mom start pumping. Don't pump and dump, first of all, but don't wait to start pumping, and have her store the milk until you figure out the answer. We also need to consider that the alternative is formula, and that the vast majority of medications result in very low levels in the milk and therefore very low levels to the baby. So we have to consider the risk benefit of that versus the risks of formula and lack of breast milk. Medications that I commonly get questions about include chronic prescription opiates as well as antidepressants, particularly SSRIs. So typically, infants have been exposed to these medications prenatally when moms are using them in the postpartum period and are at risk of NAS with opiates or a poor neonatal transition with SSRIs. These drugs both result in low infant levels in lactation versus during pregnancy, and therefore lactation is both safe and encouraged. There is good evidence with prescription opiate use during pregnancy that breastfeeding reduces NAS severity, need for infant treatment, and infant length of stay in the NICU. And similarly, for SSRIs, it's found that breastfeeding reduces the poor neonatal adaptation that can be seen with prenatal exposure. With common anxiolytics, such as benzos, for example, Ativan, these are safe in lactation with low levels in breast milk and therefore low levels to the infant. And one of the more timely medication or substances I get questions about is cannabis. So very briefly, I've given entire long talks about this, but just in a quick hits format, we really have no data for CBD products, so it's really hard to answer that question. But for other typical marijuana and inhaled marijuana THC products, they are not a contraindication to lactation. And this is specifically stated by the American Academy of Pediatrics. It should be noted, though, that we have pretty minimal data on edibles or other non-inhaled products like oils. We should discourage maternal use, but we need to balance that with alternatives and any risks they might have, especially depending on what mom's use case is. If a mom can't or decides not to stop, we should encourage lowering the THC concentration, which now we can do given that cannabis is bought in dispensaries, and reducing the frequency of maternal use. Particularly if moms use intermittently, she can consider, in this case, pumping and dumping 3 to 4 hours after use to lower the infant's exposure. Though it's important to know that with chronic or frequent use, THC does build up in the maternal fat and is slowly released into milk. So let's then transition to COVID-19. So in lactation, the Public Health Agency of Canada, as well as other agencies, recommends continued breastfeeding or maternal milk provision in mothers with suspected or confirmed COVID-19. There's no need for separation, and infected mothers should mask, though, and perform hand hygiene before breastfeeding. When we ask the question, is COVID transmitted via breast milk? We look at a case series that was published this year, in which they look at COVID milk samples from moms who were diagnosed positive. And importantly, a quarter of those infants also tested positive, but this is a very mixed picture in that most of these infants were living with families in which they were all positive as well. Some were separated from their mothers, most were not. Some mothers wore N95 masks. Some had placental pathology that confirmed prenatal infection. So it's really hard to basically make a lot of conclusions from this. But when they looked at the actual milk, only 13% of samples were positive for COVID RNA. This specifically doesn't confirm that they were infectious or had live virus, just that they found the actual RNA. And repeated tests from the same mother weren't always consistently positive. We have no evidence worldwide of any infection that has specifically been linked to breast milk. So we can pretty safely say that it does not seem that COVID is transmitted via breast milk. But can it be beneficial? So are there COVID antibodies in milk? So mothers with any viral illness typically make antibodies that are passed into milk. And these are an important source of protection because babies can't be immunized against many diseases. When we look at studies about COVID specifically, in this study from earlier this year that looked at 37 mothers' milk samples, none of these samples were positive for COVID RNA, but the majority were positive for antibodies and could neutralize COVID-19, which is very exciting. In a more recent study of mothers with COVID either confirmed or likely, They obtained samples in the weeks following symptoms, and they found that the vast majority had anti-COVID antibodies, and almost all the milk from cases could neutralize COVID. Interestingly, some of the control cases that didn't have COVID could also neutralize COVID-19, likely due to the other antiviral proteins in fresh milk, which is pretty great. So yes, we can say that milk is protective in mothers who have had COVID-19. When we looked at vaccination and lactation safety, studies aren't complete really in the lactating population because they weren't included in initial trials. But this is obviously an important question to answer now with the majority of our population being vaccinated. The Academy of Breastfeeding Medicine has stated that it is incredibly unlikely that lipid nanoparticles from the vaccine or that the vaccine RNA itself would enter the breast tissue, and even less likely it would be transferred into breast milk. And even if it were, it wouldn't harm the baby, it would simply be digested. Indeed, in a new paper, they found that there was no COVID vaccine RNA in breast milk in the days after vaccine, in which if you were going to find it, you'd expect to find it then. And more importantly, there's been no adverse events in 50 lactating mother-infant dyads. Therefore, there's no need to avoid starting or stopping breastfeeding if you're vaccinated, which was nicely stated by the British Columbia Ministry of Health website, as you see here. So we know vaccination is safe in lactation. Well, is it actually helpful? Are there vaccine-induced antibodies in milk? The answer is yes. This is an Israeli study specific to the Pfizer vaccine. And you can see time 0 is at the time of the first vaccine dose, and the black and orange lines are different kinds of antibodies. You can see after the first dose, but definitely after the second, you have this nice antibody response seen in the milk. This was also found in an American study of 50 mothers who received either Moderna or Pfizer, in which they all had significant antibodies in the milk in the weeks after the dose. And interestingly, they were similar levels to mothers who had actually experienced COVID infection and not just vaccination. So yes, milk is protective. So in conclusion, we have no evidence of transmission of COVID via breast milk in positive mothers. However, if they are feeding the infant directly, they should mask to avoid respiratory transmission. And both naturally infected and vaccinated lactating mothers make milk with antibodies that are likely protective to the infant. Therefore, breast milk provision should be encouraged as infants cannot yet be vaccinated. And here are my references.
Hi, Dr. Robin. Thank you so much for your presentation. We have a few questions that you're going to answer live. Let's start with the first one. What is the max daily cannabis consumption recommendation for lactation mothers?
So it's an interesting question, and one we don't actually have the answer to as far as an actual number. And we've like in our unit, we have kind of taken these kind of cases on an individual basis. When we have had moms who use multiple times a day, so 4 to 6 times a day, those moms we have, had some concerns about providing breast milk for extremely low birth weight infants, just because the cumulative dose could be significant. But other than that, if moms are using, once or twice a day, we really haven't had any qualms about using their breast milk. We really think the benefits outweigh the risks. But in the literature, there isn't any specific maximum dose. We do encourage moms again to limit use as much as possible if they can't stop, and to decrease their THC content. But I don't have an actual number for how much is too much.
Okay, thank you. So another question, any new data on breastfeeding for mothers with HIV? Are they eligible for breast milk banks otherwise? Thank you.
So it's another great question. So in Canada, as in most developed countries, HIV is still a contraindication to lactation, even when moms have undetectable viral loads. That being said, obviously breast milk has incredible benefits. There are studies being done, for instance, in Toronto at St. Mike's Hospital, which has a very large high-risk population, and a population of HIV positive mothers. They are looking into the possibility of using milk banks. A lot of moms who have HIV already, experience a lot of stigma and are racialized populations, and to not be able to provide breast milk is kind of a further challenge for them. And so I think that is an important question to ask. It's also a relatively small number of people, so I think it should be encouraged, at least while in NICU, to look into donor milk for those populations until there is a time in which we might be able to, for example, to pasteurize the parents' own milk, even if they're HIV positive. But at the moment, there aren't any specific recommendations.
Thank you. Talk about milk donation. Can COVID moms donate breast milk? Dr. Robban, let's answer this last question live, and then if you can go on the chat and answer more, so we can continue
Sure.
the presentations. Thank you.
Yeah, right now, I'm as far as our milk bank in Toronto, they have tested their milk samples, and a lot of their milk samples do have COVID antibodies in them. Moms that are actively ill, I don't, and to be honest, I'm not sure what the recommendations are at the moment with our milk bank, but I know in testing they have found antibodies in the milk, suggesting that the moms either had been vaccinated or had past infections. But the milk is pasteurized, so even if there were some incredibly small chance that there were active COVID, which again, we don't think is really possible, the pasteurization of the donor milk would inactivate it anyway.
Okay, so thank you. Please type the rest of the questions on the Q&A. There are quite a few more there. Thank you.
Hi, and welcome to my talk on breast programming with human milk expression, early, often, and effectively. Today, we're going to very briefly review the physiologic process of lactation. We're going to discuss common maternal risk factors that can impact lactation and long-term supply, and then finally share the evidence for a proactive approach to lactation. My goal is to show how simple interventions can help better support our families, increase mother's milk, and ultimately improve outcomes. So we'll start with a case. We have Shayna, who is a first-time mom with obesity and gestational diabetes, who develops preeclampsia, and due to that, an IUGR needs to deliver early. She hasn't yet decided on a feeding plan prenatally, and unfortunately, there's a failed induction and she goes to stat section. But the baby does well and goes to the NICU for a brief CPAP and prematurity. However, after delivery, mom is told to hand express, which she does a couple times, but doesn't really get any milk, so stops because it's not really working. But then the next day, when it's asked if there's any milk for the baby, a pump is finally brought in. Mom uses the double pump as a single because it's easier, and her breast really hurts, so she doesn't really want to use it very often. So she pumps a couple times a day and then sleeps at night. However, she's able to produce some milk, and she brings the 5 mLs of milk the baby needs, so she's happy and the NICU is happy. She's then discharged home on day 3, but doesn't yet have a pump, so she hand expresses and then goes out to buy an electric pump. But she buys a single pump because she doesn't think she'll need it for long, and finds at home when she pumps less often, she gets more milk each time, so she goes down to pumping 3 times a day. Now, clearly this case is supposed to be a little absurd, but we're going to talk about all of these risk factors and how we can mitigate them. So first of all, a lot of the risk factors that can affect lactation, like first-time mom, obesity, overweight, etc., even though they're very common, we really can't change these. But what we can change is the timing of milk expression and the frequency of milk expression. We can share the science with families so they can make informed decisions. So to really understand these recommendations, I'm going to very briefly review the physiology of lactation. Don't be scared. We're gonna be brief, but I think it really helps understand recommendations. So in pregnancy, secretory differentiation occurs, which basically means the breast gets ready to make milk. But it doesn't make much milk during pregnancy, just colostrum. And it's only made in small amounts because you can see on this diagram of the cell, the spaces between the cells are big, they're leaky. And so even if you make a bit of milk, the components of the milk leak back into the maternal blood and ultimately are urinated out. However, after delivery, secretory activation should occur, typically within 3 days after a healthy term delivery. And this is due to a complicated host of hormonal changes, but especially the progesterone drop you see when the placenta delivers. This then allows prolactin, a really important hormone, to catalyze the closure of tight junctions in the mammary epithelium. Now, this closure basically makes lactose get stuck in the gland. So those spaces between the cells, they get tight. So they're no longer leaky. Lactose gets stuck in the gland, it pulls in water, and voila, you make milk. And moms get that funny, kind of warm, lumpy, or hard feeling in the breasts, signaling that their milk has come in. Now, secretory activation, or your milk coming in, is really just the first step. After this, you need breast stimulation and milk removal for that continued process. So, coming to volume, which is making at least 500 mLs of milk a day, and ultimately copious milk production to support the baby for the next months to years. Importantly, each breast has local control. So, if you just pump or use one breast, you'll only make milk from that breast. And these first few days to weeks are absolutely critical for this concept of breast programming. So, setting the breast up for success for long term lactation, which I'll talk about a bit more. So, that hormone I mentioned, prolactin, is very critical in this early period. It does a lot of things. We talked about it closes those leaky junctions in the cell so you can actually hold milk in the breast. But it also upregulates genes that make more lactocytes, which then allows you to make more milk, which is really important if moms deliver early and didn't have the full benefit of breast development during pregnancy. Prolactin also prevents apoptosis or death of lactocytes, which again then allows you to make more milk. So high concentrations of this prolactin hormone are released with suckling or suction, especially in the first few weeks of breastfeeding, and they are really, really critical. And if you don't have that high dose of prolactin, you really can affect breastfeeding for the duration. What's really important as well, particularly in the preterm infant, which is my specialty, is that babies early on in the preterm period don't need a lot of milk. Now, in the healthy term baby, those first couple of days of life, they don't get a lot of milk, but mom's supply quickly goes up to meet the baby's needs. That preterm baby with lower needs, though, will eventually be a term baby. But weeks down the road, when they actually need that milk, it's really hard to suddenly change a mom's supply. This then makes exclusive breastfeeding difficult if she only has enough milk to feed that baby when they were preterm. So all moms, regardless of when they deliver or how much milk their baby initially needs, really need to program their breasts and build their supply in the first hours and days and weeks of lactation. This also leads to the importance of coming to volume, which is reaching that critical amount in the first 1 to 2 weeks of lactation of at least 500 mLs of pumped milk a day. And others have shown that reaching that volume in the first 2 weeks, at least in the preterm population, really strongly correlates with still breastfeeding at NICU discharge. So, as a healthcare provider, what can I do to help moms? So, it's important to share this science that it's so critical early on to initiate milk expression, whether it's with a baby or with a pump, early, often, and effectively. So in the term baby, this is easy just by following the baby-friendly policies. So breastfeeding really as soon as possible after delivery, definitely within 1 hour, even after a C-section. No formula supplementation unless it's actually medically indicated, such as hypoglycemia or significant weight loss, and rooming in and on-demand breastfeeding. Now, your late preterm or near term, those babies are actually tricky. And I have this picture because they're disguised as term babies, but they don't act like it. And unfortunately, they're often not in the NICU either. So they kind of slip under the radar. They have rapid fatigue with breastfeeding and they slip off the nipple. They have to be woken up to feed. And all of these result in the potential for inadequate stimulation and emptying of the breast. So they might be on the breast for 20 minutes, but not actually doing a lot, which then puts the mom at high risk for a decreased milk supply if she's not pumping afterwards. Because again, this breast is not being adequately programmed by this late preterm baby. These families really need proactive lactation and nursing support, which can be challenging because they typically have a very short hospitalization, often going home with mom. As interim infants, skin to skin and rooming in are definitely beneficial. Now, for the NICU infant, it's critically important as well to initiate expression early. And this is challenging because these moms are often sicker or recovering from C-section compared to term moms. But we still really need to share this science, ideally prenatally, so moms know what to expect. There's been multiple studies by Leslie Parker's group, and I'll share a couple here, that look at early lactation initiation in moms who deliver very preterm infants. And they have found that the importance of pumping within the first 6 hours is critical. She's done multiple randomized studies. The study on the left randomized mothers to within 6 hours or after 6 hours of delivery to start double electric pumping. And just based on that first day, just a few hours difference, the moms randomized to the first 6 hours made more milk during each of the first 7 days, twice as much milk actually in the first week. But even more importantly, 6 weeks later, they were still making more milk. And they were also twice as likely to still be lactating 6 weeks later. So again, programming the breast even in those first few hours postpartum. Leslie Parker also found that in an earlier study, in the moms who started pumping in the first 6 hours, their milk came in earlier, a few days earlier, which can make a big difference for these babies. And again, these moms also had higher daily volumes 6 weeks later. She actually published another study this year looking to see if it was important to pump in the first hour versus the first 6. And fortunately for us, she did not find that, just that really the first 6 hours seemed to be the most critical. So it buys us a little bit of time in these moms who tend to be sicker. When moms pump earlier, they make milk earlier. And so we need to make sure they're pumping so then they have a critical supply of milk in the first few days. Because multiple studies have shown that low volumes on day 4 result in a much higher risk of formula feeding all the way at NICU discharge. So we talked about early milk expression. We also need frequent milk expression. So healthy term and many late preterm infants, this is on-demand breastfeeding. So breastfeeding even every hour if the baby wants it. For mothers who are pump dependent for initiation, they should be pumping for 20 minutes every 2 to 3 hours, at least 8 times a day. And really importantly, not sleeping through the night, not going longer than 5 hours at once with not pumping during the night. They certainly wouldn't be sleeping for more than 5 hours if they had a healthy term baby rooming in with them. So they really need to do the same even if they're pump dependent. So early, often, and effectively. So what do I mean by effectively? So in the pump dependent mom, which pump should she use? So this is a nice review that goes over all the different use cases for various pumps. But when you're pump dependent for initiation, specifically you should be using a double electric pump and ideally a hospital grade. And if that's not available, then the next best is a personal home double electric pump. So why is this? So the double electric pump, when the breastfeeding baby is not available or unable to do the job, programs the breast best for long-term lactation. And if you pump both breasts at once, it's found that moms make higher volumes both early on, but weeks later, potentially because the body thinks you're pumping for twins, even if you're not. And importantly, hand expression alone is not adequate to establish a milk supply in pump-dependent mothers and should really never be used alone in at-risk moms. It's fine to use a bit of hand expression to get out thick colostrum that might be hard to get out with the pump, but it should always be followed by pumping to program the breast. So why is this? Well, it's because when infants breastfeed, they use suction and compression, which then releases prolactin and oxytocin. A pump uses suction. Hand expression just uses compression to remove existing milk in the breast. But it's only suction that causes the release of that all-important prolactin. So when you hand express, you're not causing a prolactin release. You're not causing that feedback loop that ensures that those lactocytes, those milk-making cells, are going to basically continue to make milk. This has also been shown in randomized studies. I'm actually going to focus on this study here on the right by Lucier, which is a really nice study that randomized mothers of very preterm infants to early hand expression versus double electric pumping. Now, moms that did hand expression made significantly less cumulative milk, only about a third as much milk in the moms who used a double electric pump in the first 7 days. This can clearly mean the difference between an exclusive mother's milk diet versus donor milk. But really importantly, if a mom changed to pumping after 7 days, it's actually never caught up with the moms who were early pumpers, even at 1 month of life. So you lose that opportunity to program the breast with a double electric pump, and you really can't go back. So going back to our case, Shayna, who's a primate with obesity and gestational diabetes and developed preeclampsia and had many risk factors. What were her challenges? So she was a primate, again, multiple medical risk factors. The baby was born early via section. She was undecided on her feeding plan prenatally. And unfortunately, the baby and mother were separated by the NICU. And the baby could not feed at breast, making her pump dependent for lactation initiation. So how should we have supported Shayna? So early, and if possible, prenatal counseling on the importance of her milk, that it's like a medicine. So hopefully she can be ready to pump immediately after delivery, and how important this timing is for long-term breast programming, timing that we can't get back. She should be doing early, frequent, and effective expression with a double electric pump, and hand expression alone should not be used routinely for pump-dependent mothers. She should have early, frequent, and proactive lactation support with close monitoring of how much milk she's making in the first 2 weeks to help support her further. Early skin to skin in the NICU. And then once baby is ready, early attempts at breastfeeding, but with pumping afterwards until breastfeeding is effective with good left and good milk removal, again, to ensure breast programming. What's also important, and something I like to emphasize early on, is that when moms first start pumping, they really need reassurance. When you can visually see that there's not much milk, it can be frustrating and scary. So we need to reassure moms that drops or really no milk output at all with the first few pumping sessions is completely normal. And to reassure them that the purpose is really not to make milk per se early on, but it's to program the breast to make milk for the long term. So we really need to focus on the bigger picture. So in conclusion, establishing an adequate maternal milk volume is really the most important lactation-related responsibility early on, and it really should be urgent. We can't get this time back. You're here, hopefully, so we can educate our frontline providers, and ideally, proactive lactation consults are available. So lactation initiation, I hope I've shown you that it's a one-time event. That success results in full secretory activation, closure of those tight junctions, and great milk volumes with adequate breast programming for long-term lactation. But if we miss that window, we can have partial secretory activation and not full closure of the junctions, lower milk volumes, and a lower likelihood of exclusive or long-term lactation. So we really want to set our families up for success to meet whatever breastfeeding goals that they have. Thank you. And here are references.
Dr. Hoban, thank you so much for your presentation. I have to say that after my C-section, the labor and delivery nurse brought a double pump to my room and I started crying because I want to breastfeed my son. So I had no idea that I could not breastfeed my 26-week waiting 2 pounds right away. And I really attributed the success of my journey to that moment where I started pumping right away. So thank you for that. So we have quite a few questions. I'm going to try to get to as many as possible. The first one is from Emily. Is hand express in the first 24 hours comparable to double pump in the first 24 hours? Or is it still preferable to double pump immediately?
So I think, the evidence I shared in the presentation, I think is pretty strong that double electric pumping is really far superior to hand expression. If you don't have access to a double electric pump, it's certainly better than hand expression, is certainly better than nothing. But to get that really critical prolactin surge, an electric pump is really, really ideal, especially for moms that are initiating lactation that way and don't have a baby that can breastfeed adequately.
Okay, so we have a question from Lisa. It sounds like recommending purchase a pump for all mothers is an important suggestion for long-term breastfeeding. Speaking from my own experience 10 years ago, I had to rent a hospital-grade pump a week after delivery, and given high cost, difficult to keep for long-term. She said, sorry for the second part to this comment. What are feasible options for low-income mothers who might not be able to afford an expensive pump? Great question, Lisa. Thank you.
Yeah, no, and it's a great question. That's a really important, I think, public health question. So in some of the talks that follow, our lactation consultants are going to discuss, for example, our program at Sick Kids, in which we have a free loaner rental program for hospital grade pumps. For other families, there's also, for instance, in Ontario Works. So mothers who are on public aid have access to double electric pumps as well. But there can sometimes be a period of time that it takes to get those pumps from Ontario Works, from insurance companies. And so to have access to at least a stopgap that's ideally provided by the hospital, in my opinion, is incredibly cost effective. We know that donor milk is incredibly expensive. Formula has a risk specifically to the preterm population that can be devastating and expensive. And so parent's own milk is an incredibly cost-effective intervention at the hospital level as well as the public health level. So I think we really need to encourage our administrators in hospital as well as our public health administrators that these pumps really need to be covered and to be easily accessible.
Absolutely, this is so important. The next question is from Brock. For colostrum, is it best to hand express before or after pumping?
I typically recommend after, just because then you've had time to do that breast programming, and then at the end you can, if you need to get the thick colostrum out, you can hand express. It's not necessary for a lot of moms. They don't necessarily need to hand express to get the colostrum out, so you might not have to, and then you can save yourself a little bit of time, because I think, as someone else pointed out, pumping is incredibly challenging and time consuming. I pumped for 2 years. I know, literally and figuratively, it sucks. It's incredibly hard. And I think we need to recognize that and appreciate that with our families. I think we can't just say, like, here's a pump, go ahead, and expect that that it's not challenging. It is incredibly difficult. And kind of to answer the question in the chat about how we can balance stress along with lactation support, it's important to, I think, give parents the education so they understand why we're kind of giving, not pressure, but giving them this information early on, because this is really a time limited period that we can't get back. But emphasizing that any milk that mom gets is a success. Even if it's drops, if it's exclusive breast milk, if it's anywhere in between, that's amazing. But also, how can we best then support them to be able to pump? Can we have hospital grade pumps at the bedside so she doesn't have to leave baby's bedside? How can we ensure that her partner or her family is doing everything they can to support her? So all she should be doing, I tell her, is eating, sleeping, and pumping. And you need to try to figure out how other people can help you do the rest. So dad or partner is cleaning the pump parts, and kind of doing everything else that the family can to support this, because as the lactating parent is the only one who can do that job. And how can we best support them to do that as much as possible?
Absolutely, that is so important, especially when you're, as she mentioned here in her comment, you pump every 2 hours, 8 times a day. It is exhausting, especially in the middle of the night. So having create some support system around when possible is, I think, is very important. So thank you for that, Lisa. So the next question from Renee: what's your view on the early use of formula for the treatment of hypoglycemia versus initiating IV fluids to stabilize the glucoses until breast milk is available for the first feed? Thank you, Renee.
Yeah, so I think presumably this refers to the more the healthy term population or late preterm populations. I think that there's actually very mixed evidence for what we should do. And a third option is donor milk, which some hospitals are also using, but it is quite expensive given the fact that these are typically big babies who eat a lot. So I think you have to weigh the risk benefits. We know that formula does change the microbiota of the baby for months to come. But IV fluids often mean that the baby has to be separated from the parent and go to the NICU. And that's not great either for milk supply, for mental health, or for bonding. So I think it's really a discussion with the family as to what works best for them and what their goals are. But also, if the baby is getting formula, for example, to make sure that the baby is still going to breast first, or mom's still pumping first and then supplementing, to make sure that programming is still happening and that formula is not a failure. both of my children were supplemented in the first days. I cried. I thought I was the worst lactation expert in the world. They survived and thrived, and they're incredibly healthy. And I was able to then breastfeed them for over 2 years. So it's getting over that little hump. It's okay. And again, to reassure families that it's okay, and they're still a success, and we value any milk that they can give.
Absolutely, this is so important because mothers or parents actually can feel guilty sometimes of not being able to have as much milk or give a formula or using a donor milk bank. So I think it's important for us to give the message with the positivity so the families don't feel guilty for the ones who choose to breastfeed. So I have a question here for Rachel. Does providing a pumping log to track frequency volumes for moms increase rates of milk establishment? I really like this question. I think Laura is going to answer live on her talk. I don't know, Rebecca, if you want to address that or if you leave for Laura to answer after.
I think Laura can definitely answer later as well in their talk. I always encourage it. I think it just, as again, a mom who's pumped and breastfed in the past, you're foggy. You don't remember when you last pumped. I think it's helpful to keep track. And to then, realize a couple hours can go by quite quickly, and to make sure you're trying to stay on track, especially in those first couple of days with frequent pumpings. I encourage it, whether it's an app, paper, like whatever works for you.
Okay. Well, there are so many apps now available for families to keep track as well. So there's a question here from Catherine. With the World Health Organization breastfeeding, breast-friendly initiative, is pump rental permitted? I hope I get your question right, Catherine.
I don't know if I understand the question as far as pump rental permitted. I don't think they specifically address that in baby friendly. I mean, but it should. However, you can facilitate getting breast milk should be encouraged. I don't think they specifically discuss pump rental with the WHO.
Okay, let me see what else is here. There's a lot of questions on the chat. So Jacqueline, the lactation consultant will answer some of the questions they already put here. The mothers of late preterm group in Calgary tends not to have the same feeding and pumping advice live in the units. Any comment on that, Dr. Hoban?
I'm just scrolling through the questions. Which one more time?
Paula made a comment about the mothers in Calgary.
Yeah, I mean, I think that is definitely true. There is a lot of variability between NICUs. We definitely see that with referrals from our hospitals as well and our catchments, especially with waiting to pump, waiting to express in those first couple of days. I think we have the evidence. We know that quick pumping or quick breastfeeding in the first few hours of life is very critical. In the late preterm population specifically, we really need to make sure that if the baby isn't effectively removing milk, that moms are pumping afterwards, again, to promote programming. The late preterms are tricky because they also have a very short length of stay. So they have, they don't have a lot of access to lactation services, but they're not good breastfeeders when they go home. So it's really vital for them to get outpatient follow-up.
Absolutely. And we know during COVID, there's a lot of lactation consultants offering virtual appointments. So I think we have to know all those resources to recommend to families. Yep. So I have a question here from Rose. I work with higher risk populations. Many families express financial difficulties with purchasing a double pump. What are the recommendations to using a single electric pump?
So again, if that's all that families are able to access, single electric pump is definitely better than hand expression or better than a manual pump. Again, would encourage hospitals that this should be a priority for them, and that they should have pumps that moms can access during NICU hospitalization. And with public health programs, there should be opportunities for moms to access double electric pumps ideally. But obviously that's in an ideal world.
Okay, so we still have obviously a lot of work to do in Canada to make it accessible to all families.
Everywhere.
Absolutely. Yep. So I have a question here from Sarah. What is the best practice for cleaning and sterilizing pump kits in the NICU? Currently, our level 2 washes them like dishes, then sterilize in microwave for 3 minutes. Is this two-step really necessary? Thank you, Sarah.
So So if you're not, so the ideal thing is to have the sterilizing dishwashers in the NICU, which are currently the recommended practice. And that one, you don't have to do 2 steps. You literally just put them in this 3-minute high-powered dishwasher and they're sterilized. Obviously, that requires infrastructure. So if you don't have access to those, then you do unfortunately need to do the 2 steps, because if you try to just sterilize them in the microwave bags without washing them, then you need to get the milk off. In a term baby, it's not obviously not at all necessary to sterilize in between uses, just to wash off and let them dry like dishes. Ideally to sterilize once a day. But in the high risk or preterm baby, ideally they are sterilized after each use.
Okay, so the last question we have here from Caitlin, renting is only $50 for 2 weeks. I wish our NICUs had more availability to cash for families to help bridge this gap. Do you have any recommendations on how to start a program within an NICU setting where donations could be made for something like that? This is such a great question. So what is your take on it?
Well, that's kind of a perfect setup for literally the next talk in this workshop, which specifically addresses how we set up our pump loaner program at Sick Kids. But we do have, for families where they're not able to access that, our social workers are able to bridge those gaps as well. Again, like trying to have these discussions with your hospital administrators. This is also how we got, for example, our lactation consultant in the NICU full-time supported, because I presented the evidence at the hospital level that this was actually a cost-effective intervention. The hospital would save money if they put this relatively small amount of money into pumps, into a lactation consultant. The big picture would be the best thing for babies, which should be the priority, but financially it also makes sense.
Okay, Dr. Hoban, that's it for you for now. All the other questions on the chat, the lactation consultant will address after their presentation. Thank you, Dr. Hoban, and thank you all of you for sending your questions. We love your comments. So I let Dr. Hoban take the next step. Thank you.
Right. So for the next part of our talk, we're going to transition to our amazing lactation consultant team at Sick Kids. So we have a team who specializes in our high risk medically complex babies at Sick Kids, but also has experience in perinatal lactation consultancy as well as outpatient LC work. So I was really excited to bring them into this workshop. They're our frontline providers who do really all of the work at Sick Kids to help facilitate our lactation success. So they're going to be doing 3 different talks, and then there'll be a 4th talk at the end specifically for hand expression by one of our perinatal nurses. So just like with these previous talks, there'll be time for questions after each one. So for this upcoming talk, they're going to talk about pumping and protocols, as well as practical tips and the pump loaner program. And then importantly, there'll be a 10-minute break after this talk in case anyone needs a bio break or needs to grab some water. So thank you again so much to our amazing lactation team, and I'm excited to see what you have to say.
Hello everyone, and thank you for inviting our Sick Kids LC team to present at today's workshop. Our presentation today is titled How and Why to Facilitate Lactation Success, Pumping, Protocols and Practical Tips for the Perinatal and Neonatal Team. Today's presentation will be divided into 3 parts. Part 1, presented by myself, will discuss promoting breastfeeding success. Part 2, presented by Laura and Jackie, will cover troubleshooting some of the common lactation challenges we see in the neonatal period. And then Part 3, presented by Glynis, will give an overview of some of the practices that can help to improve neonatal outcomes. So to begin, Part 1 will cover the Sick Kids breastfeeding pathway, a review of pumping recommendations, normal milk volumes, and the importance of a loaner breast pump program. The pathway to breastfeeding was developed by our LC team at Sick Kids to help illustrate both the steps involved in the support of breastfeeding and the provision of breast milk, and why each individual step is important to the overall goal. It is also important to remember that prenatal education is of utmost benefit. To support this, our team sees those families whose baby will be coming to Sick Kids for cardiac care at a prenatal visit. This allows us to discuss the importance of getting on an early start on pumping, oral immune therapy, and kangaroo care. At this visit, we also supply them with a set of pump kits that can be used on the maternity ward at their birth hospital and then at Sick Kids once they are discharged. We also supply them with a breastfeeding resources booklet called How to Make Milk for Your Baby that has instructions for pumping and links to teaching videos that cover pumping, oral immune therapy, and kangaroo care, as well as our team's contact information. In order to support the importance of starting early, our team connects with parents as soon as possible, ideally within 24 hours of admission to Sick Kids. If parents are not able to visit the hospital right away, we call them to ensure that they have what they need to begin hand expression and pumping, both on the maternity ward and then at home. We highlight early initiation, ideally within 6 hours of birth, and encourage hands-on pumping and hand expression. Guidelines for pumping frequency are discussed. Pumping as often as baby would feed or a minimum 8 times in 24 hours. Having only one 4-hour stretch without pumping. Pumping at least once at night as baby would be waking to feed at night and prolactin levels are higher during this time. Double pumping both breasts at the same time for 15 to 20 minutes or until the breasts are adequately drained. Jackie will be discussing hands-on pumping in detail in part 2. Using a hospital-grade pump when available, and at Sick Kids, hospital-grade pumps are available on all inpatient units and in our pumping rooms. Once parents are able to visit, we encourage them to initiate oral immune therapy and kangaroo care. And then once baby is stable, we support parents to initiate time at breast. Each family receives a set of pump kits and our breastfeeding resources booklet at our initial consultation. That's if we didn't see them prenatally. As you know, at times hand expression is more effective at removing colostrum from the breast in those early days. However, it is also important for mums to pump in order to stimulate the breasts. The two in combination have been shown to promote higher milk volumes. Jordan will be discussing hand expression in further detail in her presentation. This slide reinforces the importance of early and frequent breast stimulation in order to set up and prepare for the supply and demand system to initiate and continue to build supply so that when baby is ready for full feeds, supply is also. Sometimes the belief is that the baby is not yet feeding. The breast will just wait for the baby. We often must reinforce with parents that the breast needs to start this process right from the start, even if baby doesn't feed for a number of days or weeks. This, of course, means starting the process on the maternity ward and continuing this same pattern of milk expression once parents are home. This also applies when feeding is interrupted for medical, surgical, or other reasons. Parents need to continue to stimulate the breasts, trying to mimic baby's typical feeding pattern in order to maintain their milk supply. This picture of supply and demand is one of the pages from our breastfeeding resources booklet. It is given to all parents along with their pump kits and contains information regarding pumping, the how-to, how often, and how much, as well as how to clean breast pump kits in hospital and at home, how to store milk and bring it to the hospital, and where to buy and rent pumps, and also a pumping log. When we meet with families either pre or postnatally, we review the booklet with them while discussing the points in detail. We find that this helps to ensure that nothing is missed, that questions are answered, and families have all the information they need to get started. They can also add their own notes to the booklet as we go through it. Our team contact information is also on the back, and we encourage families to call or email us with any questions if they are at home. If they are visiting the hospital, we ask that they have the bedside nurse or the clerk page us to meet with them in person. This is the milk volumes page from the booklet. We find it is very important to highlight typical volumes beginning at day 1 postpartum. Parents often think that either there is nothing there for those first few days, or that milk should be available in large quantities right from the start. Reassurance that a few drops is great and that continuing to pump and hand express regularly will help to build supply is critical information for parents, otherwise they will often not pump since they may not be getting much, or they will wait until their milk comes in, or sometimes even until their baby is able to breastfeed. Reinforcing that this is normal and encouragement to keep going is important, as is for parents to understand that even if baby is not receiving milk or breastfeeding now, their breasts need to be stimulated and milk expressed effectively for them to be programmed to make milk for now and later on when baby is ready to feed. This is our pump log, and as you can see, there are columns to track how often and amounts of milk. Then a spot at the end to add the 24-hour totals to keep track of overall volumes. Tracking 24-hour total volumes helps families and healthcare professionals like us to assess if supply is adequate. Parents can also log their kangaroo care. As you have probably seen, there are also a number of apps for tracking pumping, and families love these as they can download them onto their phone and they're easily accessible. They also do wonderful graphics to show volume increases, which is great visual encouragement for parents. There are 2 recommended hospital-grade pumps. Both companies make a number of different styles from manual to double electric. The double electric pumps made by these companies are very reliable and can be regulated for both speed and suction, as well as having been built for frequent long-term pumping. Flanges are also available in different sizes for these brands. They are recommended for use by families with babies in the hospital and for those who are pump dependent or wishing to do long-term pumping. Having a loaner program is very beneficial to families. It allows those families who have not yet decided on a pump to have access to a double electric pump right away. This encourages pumping early and often right from the start. Giving free kits, both for use at the bedside and along with the loaner pumps, also supports regular pumping, as it ensures that families have access to pumps and kits while visiting the hospital and then also when they are at home. Our program gives kits to families either prenatally during a visit to sick kids for consults or postnatally when they are visiting their baby. The breastfeeding resource booklet is also given at this time. We encourage parents to buy or rent a pump within the first 2 weeks after the birth of their baby, so that we, our LC team, can make sure that our pumps are consistently available to other new families. As mentioned, information regarding rental and purchase of pumps is included in our breastfeeding resources booklet. Most of our families are encouraged to purchase a pump as they will need it longer term. We can also negotiate the length of time parents have the loaner pump depending on their individual circumstances. Exploring options in your organisation for the funding of a loaner pump program is worthwhile. Every family then has access to a pump quickly and can begin pumping regularly right from the start, which promotes the value of breast milk, especially for our high-risk populations. Our loaner pump program is managed by the LC team and has these parameters. We require a credit card deposit and a signed rental agreement, which parents also agree to return in the pump within 1 week of discharge or transfer. We also have a partnership with the business office in our hospital who process the deposit payment. They hand out the pump once the forms are signed, and they also complete the deposit refunds when the pump is returned. To support parents to acquire their own pump after discharge, social work are often contacted by us as they can help with either funding within the hospital or help parents apply for Ontario Works or other social assistance programs for those who qualify. We also complete insurance letters for families who have workplace benefits that will cover the purchase of a pump. So here we have a case scenario, Katie. So Katie delivered a 30-week-old baby by C-section at a community hospital. While Katie was admitted, her postpartum nurse advised her to pump every 3 hours and sleep at night while she recovered. Katie continued with this pumping schedule after discharge. She's also been using a single electric pump. On admission to the level 3 NICU at 1 week, she was assessed by an LC and found to have low milk supply. Katie would like her baby to only receive breast milk. What has caused this low milk supply, and how can we advise her going forward? Katie has followed the advice of her nurse. She has been pumping every 3 hours and sleeping at night. As a result, she has not been stimulating and expressing milk often enough. She's also been using a single electric pump, which has made her pumping sessions longer than needed and less effective. These things have contributed to Katie's low milk supply. Early lactation support is critical for breastfeeding success, especially in our high-risk population. This allows parents to make informed decisions about feeding their premature or sick baby. As mentioned, starting early is key, ideally within 6 hours of birth. Facilitating pumping with a double electric breast pump and promoting hands-on pumping, followed by hand expression 8 to 12 times in 24 hours is crucial in establishing a milk supply. Reminding parents that baby would feed at night, so it is important for them to wake and pump at least once during the night. Following these recommendations promotes the establishment of a full milk supply, provision of breast milk, and long-term breastfeeding success. To support Katie with these recommendations, encourage her to have self-care, naps and rest during the day, good nutrition and fluids. She should take pain meds as prescribed or needed, and encourage the family to be involved and supportive with the process of making milk for baby. This is the end of part 1. Thank you for listening. This is your opportunity to now ask questions.
All right, so it looks like we have quite a few questions. I did type answers to some of them just so we can kind of continue on. But if the LCs can answer a couple of these now. So we answered this a bit, but question from Rachel is, does providing a pumping log to track frequency and volumes increase rates of milk establishment? And you guys are all muted. There you go.
So I
Thanks,
think,
Laura.
sorry. So I think, yeah, Samantha covered it in hers for the most part, but yeah, it can be very good to track it, because if not, it's easy to not realize that there are bigger gaps in pumping than one thinks, and it's easy for a parent to forget how often she's pumping. And also seeing the 24-hour total can be very helpful, because when they start to pump more frequently, they may get less milk every time. And if they're not looking at that 24-hour total, they may mistakenly think that if I wait longer, I'll get more milk, which we know will actually program the breast to make less overall.
And I think as a healthcare provider, as a neonatologist, it's really helpful for us as well to know how much they're making in 24 hours. We encourage our nursing staff to report the actual volume pumped per day in the first 2 weeks, as opposed to, oh, volumes are fine or volumes are good, because that often means that it's enough for the baby, but the baby might be, taking 20 mLs a day. And so if the mom's literally only making 20 mLs a day, that's not good. That's not okay as far as long-term lactation if her goal is exclusive breastfeeding. So I think that those logs could be helpful for everyone, for parents as well as healthcare providers. Next question, do you think a consult with an LC prior to delivery would be helpful for moms who might face a lactation issue after birth? I assume you guys have a little bit of a bias, but how would you answer that question?
Well, in an ideal world, everybody would have a prenatal consult for sure. But we actually we found it was a great need here at Sick Kids, just because we're not a delivery hospital, a birth hospital. So sometimes we wouldn't be able to see our patients for 24 to 48 hours after delivery. So we actually started a program, I think it was a few years ago, that we met with our patients, like high-risk patients, like cardiac kids, like gastroschisis and abnormalities, genetic abnormalities beforehand. And that way we would give them the pump equipment that's needed for pumping. We'd give them our breastfeeding resource booklet. So it had all the information there ahead of time. So it was very, very helpful.
What are your thoughts about the hospital charging for a pump kit? The hospital I worked in used to provide pump kits for free, but now charges for them, which deters mothers from initiating early pumping.
Yeah.
Yeah.
So we're really lucky here at Sick Kids that we actually have funding to cover pump kits. I know not all hospitals have the funding available for that. So I think, again, you have to look at your organization and somehow, you know, show the evidence and the support for giving these free pump kits to parents. Just because a lot of times these parents can't afford it, which is very unfortunate. But yeah, like here at Sick Kids, we're really lucky to have that funding and support behind us.
And we put together a business case actually
Mhm.
too, because there had been a plan to start charging, which obviously we were incredibly angry about. So we put together a business case showing that basically this would encourage parents to either formula feed, which although that was cheap for the hospital in the long term, was very expensive for the family in the long term. Once you go home, formula is incredibly expensive. Or if families didn't have access to pump kits, then the hospital would provide donor milk for preterms, which is incredibly expensive. So again, it's cost effective and it's just the right thing to do. You really shouldn't be punished for choosing to lactate. And that's basically what you're doing. If you are charging for a pump kit, you're punishing parents for the opportunity to provide their own milk versus free donor milk, which I think is obviously, I think is crazy. But again, working with your hospital administrators to really show them the science. I think we maybe have time for one more. What is your ideal follow-up within the NICU? You see prenatally, and then within the first 24 hours, do you follow a certain routine?
So it can depend on what's going on with that particular parent. If so, we usually like to see them again within a day or two. If they're having any difficulties, if they're at risk for any problems, engorgement, anything like that, if they're having any pain with pumping, then we'll definitely try to make sure to see them the next day. Whereas if things are going well, and particularly if they're comfortable with the pump, if it's not their first baby and not their first time having to pump, then we might wait 2 days. But we don't usually in that first week ever like to go more than 2 days.
And we really focus on those first 2 weeks as kind of that critical time that we can't get back. Perfect. Fabiana, how are we on time? Do we have time for one more question or do we need to move on?
I think you can go one more.
Okay, let's do one more. Is there evidence that when using an electric pump, going back up to a higher speed when milk stops flowing to re-stimulate letdown? Is this effective?
So I mean, when we do that, it's just mimicking the way that babies suckle at the breast, but there is some evidence to support that it does trigger the letdown. I don't know whether the evidence is strong for whether or not it triggers a second letdown, but there is at least one study that I've found from 2020 that does make that recommendation based on the study that they did in having parents do that.
Perfect. All right. Thank you so much. And a lot of good questions. And again, I answered a few of them in the chat as well. So now we're actually going to go on a 10-minute break. Everyone can grab a snack or pump if you need to. And we'll come back for 3 more LC specific sessions.
It might seem crazy what I'm about to say. Sunshine, she's here. You can take a break. I'm a hot air balloon that could go to space with the air like I don't care, baby. By the way, because I'm happy. Clap along if you feel like a room without a roof. Because I'm happy. Clap along if you feel like happiness is the truth. Because I'm happy. Clap along if you know what happiness is to you. Because I'm happy. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Hey, go, bring me down, can't none bring me down. Your love is too high, bring me down, can't none bring me down. I said, bring me down, can't none bring me down. Your love is too high, bring me down, can't none bring me down. I said, clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Clap along if you feel like that's what you want to do. Hey, go, bring me down, can't none bring me down. Your love is too high, bring me down, can't none bring me down. I said, clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Hey, hey, hey. Clap along if you feel like that's what you want to do. Clap along if you feel like a room without a roof. Clap along if you feel like happiness is the truth. Clap along if you know what happiness is to you. Hey, hey. Clap along if you feel like that's what you want to do. we're together as we walk on by. And we fly just like birds of a feather.
All right, welcome back. I'm not going to lie, that online countdown gave me PTSD from virtual kindergarten with my kids last year, but hope everyone had a lovely break. We're now going to be coming back to our Sick Kids LCs for part 2, troubleshooting common lactation challenges. And again, please continue to type your great questions in the question section.
So part 2 will cover common lactation challenges in the neonatal period. Some of the challenges that will be discussed are problems with pumping, causes and treatment of breast and nipple pain, identifying low milk volumes and how to help a mother increase her milk supply, and how to effectively double pump while doing hands-on pumping. So you have a mother who's complaining of pain when she pumps. What do? Here's a quick checklist for pain-free pumping. It is very important to remember, pain with pumping is never normal, and it needs to be addressed right away to prevent any nipple damage. The first thing that you can check is to make sure the nipple is centered in the flange. I will show you a picture of this on the next slide. If it's not centered, the suction can cause abrasions on the surrounding areola. Another check that you can do is make sure the parents are not putting their suction too high. Higher suction does not mean more milk. A lot of parents will think that if they increase the suction pressure, more milk will come. It actually does the opposite. If pumping is painful, parents are less likely to pump as often, and oxytocin is affected by pain, which can interfere with the milk ejection reflex. Another aspect of pumping with a high suction is that when transitioning to breastfeeding, the milk letdown reflex has been set or trained by the pump, and it may take some time to recalibrate that hormone cascade system to be sensitive for when the baby's actually on the breast, which means moms may not have a milk letdown when baby actually does some normal sucking on the breast. We encourage parents to ensure that their suction setting is comfortable and not too high so that when they do transition to direct breastfeeding, we can synchronize mom and baby quickly and easily. Another check you want to make sure is that pumping sessions are approximately 15 to 20 minutes in length. Pumping for longer stretches can cause nipple soreness, and it's actually more effective to pump more frequently than for longer. And you also want to make sure that parents apply the flanges on the breast prior to turning on the pump, and to make sure that parents either turns down the suction pressure or turns the pump off completely before removing the flanges. This will help any unnecessary nipple trauma. And the last thing is to make sure, are the flanges the right fit? Too big or too small can cause nipple and areola damage. I will show you the correct sizing on the next slide. It is really important to actually observe a pumping session. You shouldn't just guess what flange size a mom needs to be. Most pump kits will come with a standard size, typically a 24 to 25 millimeter. So remember, in this case, one size does not fit all, so it may need to be adjusted. So how do you know if the flange is the right size? This is the handout that we use to help parents assess flange size. We also meet with our parents and join them for a pumping session, usually during our first consultation, so that we can address the flange size and adjust it if need be. So in the first picture, you'll see the flange is actually correct sizing. The nipple is fitting well in the flange, and there is space around the sides and the end of the nipple when pumping. The second picture, the flange is too small. The sides of the nipple are rubbing against the flange when pumping, and this can cause some nipple soreness over time, and also the closing of the milk ducts in the nipple causing decreased milk flow. And the third picture is actually too big. You'll see the nipple is not rubbing against the flange, but it's actually pulling too much of the areola, the breast tissue, into the flange, and this can cause a lot of rubbing and soreness. And for these patients, you actually see when they're done pumping, you'll see like a red ring around on the areola around the nipple. If mom is complaining of sore nipples and you've assessed the possible causes from pumping or breastfeeding, here's how you can help in healing them. Just remember, we aren't going to discuss this today, but if mom has sore nipples and she is pumping and breastfeeding, the latch during the feedings will need to be assessed as well for a poor latch. So some things that she can do. She can apply breast milk to the nipples and areola after pumping and let it air dry. Breast milk contains natural skin moisturizers and antibodies to help fight infection. She can also apply a nipple ointment or cream to nipples after pumping if there are any cracks or lacerations, such as like a lanolin cream that you can buy over the counter. If mom is using breast pads and they get stuck to the nipple, she should soak them off with water to help eliminate any scabs being pulled off during the healing process. And if she is using some nursing pads, a cotton nursing pad is actually preferable versus a plastic, as a cotton helps the skin to breathe more easily. And it's unnecessary to use any soap or wash the nipples prior to pumping. Your body actually has little bumps on the areola, which is called Montgomery glands, and these produce oil that moisturizes and protects the nipple. So soaps can actually strip the natural oils and cause dryness. And she can also put a cold pack or cold compress on the nipples to help soothe them. I just wouldn't use any direct ice on the nipples. Another challenge that some moms may have is a low milk supply. Samantha did go over with you the normal milk volumes for term and preterm infants. So some possible reasons for low milk supply are: one is a poor latch. If a baby is latched incorrectly, such as the latch is too shallow, the baby will not be stimulating and draining the breast well, which could gradually lead to low milk supply. Another possible reason is schedule of feeds. So, by scheduling the feeds too much and not letting the baby feed on demand as they should, the mother may be limiting the breastfeeds, which in turn is not stimulating the breast adequately, causing the milk to dry up and eventually may not be meeting the needs of the growing baby. If breastfeeding is ever interrupted, so we actually see this a lot at sick kids, a baby that is exclusively breastfeeding comes to sick kids and is admitted for illness and may not be able to breastfeed. So the mom needs to start pumping right away and regularly so that her milk does not dry up while the baby is ill. So she actually needs to follow the same feeding pattern as baby was doing prior to admission. And the type of pump definitely matters. So using a good quality double electric pump will definitely make all the difference. Using a manual or single pump will definitely affect a mother's milk supply. And there are definitely some maternal health and breast conditions that could affect supply, such as PCOS, diabetes, hypothyroidism, or even a mother that has a history of breast surgery, such as a breast reduction, or even some insufficient glandular tissue. So, how can we help boost a mother's milk supply? We always want to use encouraging words and let the parents know that any amount of breast milk is beneficial and will be given to their baby. But before we mention any additional strategies to help boost supply to parents, we need to go back to the general rule of breastfeeding or pumping. The breasts need to be drained at least 8 times in 24 hours to establish and maintain an adequate milk supply, either by pumping, breastfeeding, or a combination of both. After we've assessed this, then we can go on to some additional strategies. The first one could be a power pumping technique, and this can be done in a few different ways. The first way could be pumping every 1 to 2 hours for a period of time during the day. So, for an example, the mom wakes up and she pumps at 7 a.m. She waits an hour, pumps at 8 a.m., waits an hour, pumps at 9 a.m. So, she's really doing 2 to 3 pumps back to back, but 1 hour apart. And then the rest of the day, she can just do her normal every 2 to 3 hours. So, this mimics the cluster feeding pattern that babies go through during a growth spurt and tells the body to make more milk. She might make a little bit less milk initially just because she is emptying more often, but give it time, give it 2 or 3 days, the body will start responding to the stimulation and start making more milk. Another way to power pump is by doing sort of a 1 hour power hour. So that's kind of being on the pump for 1 hour. So she can be on the pump for 15 minutes on, 15 minutes off, 10 on, 10 off, 10 on, 10 off, and do this for 1 hour. And again, this can be done over a period of 2 to 3 days. And then after that, she might see results. So the parents just need to know that this needs to be done consistently in order for them to see the results. Another strategy could be skin to skin, which Glynis will go over in more detail during part 3. So, skin to skin is a strategy to help support milk supply. As we know, do a lot of touching, holding, bonding with their babies. Those hormones that make the breast milk increases. So, we want to make sure we encourage lots and lots of skin to skin time with their babes. Another strategy that we could use is called domperidone. So domperidone is a medication. It's considered a galactagogue. So galactagogue is a substance that promotes lactation, and that could be either an herb, a medication, or a food. And at sick kids, we typically don't recommend the herbals just because of the lack of evidence of efficacy and safety of these herbals. So we tend to use domperidone that has been studied well, and there's a lot of documentation and to support the use of the domperidone. Domperidone will usually only work if it's used in combination with a pumping. So domperidone only needs to be considered after an LC has assessed all the other reasons and options to help boost their supply. And again, Domperidone will take some time to work, so it usually takes 2 to 3 weeks for moms to see the results. Another technique that can be used to help boost milk supply is called hands-on pumping. So hands-on pumping is a technique that uses manual breast massage or breast compressions while pumping. This helps to stimulate the breast more during the pumping session. And this can be achieved with or without a pumping bra. So if not using a pumping bra, you have to hold the flanges in the pump in a certain way for it to work. So you can actually use a scissor hold, which means the first 2 fingers are around the flange, allowing the thumbs to use the breast compressions during the pumping session. If you are using a pumping bra, this actually helps to hold the pump in place, so then you have your hands free, and then you can use your hands to do the manual massage on your breasts. And the parents can either buy or make their own pumping bra. So here are some pictures of hands-free pumping bras. The pictures on the left, there are 3 different brands of pumping bras on the market that you can buy, all at different price points. And they're actually very useful since they hold the pump in place. Therefore, you have your hands free so that you can do some manual massage. The one on the right is from a sports bra. So you actually can make it yourself using just an old sports bra that you may have. You can cut two slits into the cups to allow the flanges to be inserted and held in place. So this is another creative way to make a hands-free pumping bra using hair elastics, and that's actually quite easy. So you just take 2 hair elastics, you loop them over each other, and this makes the figure 8. You put one end over the base of the flange, as you can see in the picture, and loop the other end of the elastic over the hook of the nursing bra. Then you can position the flange on the breast. And there you go, you have a hands-free pumping bra. So Laura will now discuss some possible breast complications and how to manage them.
The first complication we will talk about is engorgement. As we know, colostrum, or the first breast milk, is in well before the baby is born. However, the change from colostrum to transitional milk, which usually happens between day 3 and 5 postpartum, often brings with it a lot of swelling, and the breast tissue can become quite tight and uncomfortable. This is known as engorgement. This is another time when frequent pumping is important, as mimicking typical feeding patterns helps the breast to move through this stage. Although for some parents, even if they are emptying frequently, when the milk first comes in, they may experience some engorgement. As most of the discomfort is due to swelling of the breast tissue, pumping helps, but these other strategies will also help. Applying cold to the breasts for about 20 minutes between feeding or pumping sessions can be helpful to help reduce some of the swelling. Lying down and massaging the breast down towards the armpits will help move some of the fluid out through the lymphatic system. Doing reverse pressure softening by pressing into the areola for 60 seconds to move fluid away from the nipple before pumping or feeding can be helpful as well, especially if there's a lot of swelling in the areola. Applying heat for a few minutes just before feeding or pumping can help the milk to flow. And if needed, taking an anti-inflammatory such as ibuprofen for pain control and to reduce swelling may be needed. Some parents will experience plugged ducts quite often, and others may only have it happen if they've not had the chance to pump or breastfeed, sometimes due to the admission of their infant to the hospital. Plugged ducts are defined as an area in the breast that is not draining well, causing a blockage. There is often a tender lump that can be felt in the area, and the milk volumes may have decreased from the affected side. The main thing that differentiates a plugged duct from mastitis is that there are no other symptoms other than an uncomfortable, firm area in the breast. Mastitis, on the other hand, is when there is inflammation of the breast tissue, sometimes occurring with an infection. With mastitis, the parent is usually feeling generally unwell and may also have a fever. There is often also a red area on the breast. Mastitis can occur from an untreated blocked duct, which then leads to inflammation in the breasts. or from a break in the skin on the nipple, allowing the introduction of bacteria. Treatment for both plugged ducts and mastitis are similar, as the goal is to keep the breast comfortable by pumping or breastfeeding frequently. We also advise to apply heat, particularly before feeding or pumping. Massage from behind the lumpy area towards the nipple. However, it's important to be cautious if there are symptoms of mastitis, because an abscess can form. So if there's any suspicion that the lump is from an abscess, such as from a high fever, then do not advise the parent to massage the area. Hand expressing after pumping can also be helpful, as can wearing the right size bra and without an underwire, and loosen the bra to prevent compression of the milk ducts. Taking an anti-inflammatory if needed, and then just generally taking care of themselves with rest and eating and drinking well. If the parent has a high fever or if symptoms worsen or do not improve after 24 hours, we usually advise for them to seek medical attention because antibiotics may be needed. This slide just demonstrates some of the techniques for breast massage. It can also be helpful to massage while pumping. One of the best ways to do this is to use a scissor hold to hold the flanges on with the index and middle finger, and then use the thumb and bottom fingers to massage. A common cause behind all of these breast complications is inadequate emptying of the breasts. This can be due to not feeding or pumping often enough. One reason for this could be due to restricting feeding times rather than feeding on demand, or the infant not feeding well because of illness. Engorgement or a plugged duct that is not treated promptly can also lead to these complications and to further complications such as mastitis. A poor latch and an oversupply of milk, which can easily lead to plugged ducts. When there is a crack in the nipple, such as from a poor latch or using the wrong size flange when pumping, this can allow the introduction of bacteria, which can then cause mastitis. We are now going to look at a case scenario. In this case, Lisa delivered a full-term baby that was transferred to a level 3 NICU shortly after birth. Lisa initiated pumping as recommended with a hospital-grade pump, but has never been observed pumping. At 1 week postpartum, Lisa was asking to speak with a lactation consultant due to low milk volumes of 150 milliliters per day. She was also having some pain with pumping. What questions could we ask Lisa, and how can we proceed to help her? Firstly, it would be helpful to observe Lisa pumping. What would we be looking for? Before we even start pumping, we can inspect the breasts and look for redness, abrasions, cracks, or bruising, as this can guide us on what might be wrong. Then, once she starts pumping, we should look for how well she centers her nipples in the flanges. Often they are not able to see the vertical alignment of the nipple in the flange as they're watching from above, so it may be rubbing along the bottom or top of the flange. Check what pump setting she's using. Ensure she is using appropriate speed and suction. High suction can cause a lot of damage to the nipples and is usually unnecessary to drain the breasts. Check the flange size. Look at the beginning and end of the pump session because it can change during the pump session as the nipple might expand. We want to make sure that the nipple is moving freely, but areola is not being pulled into the flange, and the sides of the nipples are also not being rubbed. Find out how often she's pumping and for how long. Sometimes we find out that a parent has been pumping for an hour at a time, which can definitely cause some damage. After doing all of this, we're hoping that we will have found the problem. So in this particular case, the flange size was corrected as she needed a smaller flange insert, and then her pain went away and her milk volumes increased over time. In general, it can be very helpful to observe a parent while they're pumping right from the beginning, because oftentimes just a description from them of what's happening while pumping won't give you enough information. Watching them pump can tell you far more. and changing the settings or the flange size right from the beginning, as soon as possible after she needs to start pumping, can really help to prevent a lot of problems later on.
All right. Thank you so much for that great talk. And we have some good questions as well. So this is from Chelsea. I recently cared for a young mom with sensitive skin in the NICU who complained of pain with pumping. She adjusted the flanges, but both of her breasts were bleeding when the baby went to the breast. The LC said her skin was very fragile and sensitive. What would you suggest in cases like this?
It's pretty rare to have such trauma to the nipples after 2 days. So I think you have to kind of go back to the checklist that we mentioned. One is obviously looking at the latch and making sure that it's not a poor latch, making sure that's a deep, effective latch. And then also going back to checklist for pumping. So looking at the flange sizing, actually going with the mom during her pumping session to observe the pumping, making sure that it is correct sizing, looking at what she's doing for the suction pressure. And then usually with all those, usually you can like figure out what the issue is. You can also use like a lanolin cream or her own breast milk will help as a moisturizer. Sometimes one little trick that sometimes we do is we put some of the lanolin cream actually inside of the flange. So it actually has like it slides a little bit better versus if you don't have anything, it causes less of a friction when you're pumping. So other than that, usually if you kind of look at those issues, you can pretty much figure out what's causing the trauma.
Thank you. So Sarah asks, can you discuss the benefits and disadvantages of using a Haka pump? So for those who don't know what that is, it's like a silicone manual pump. I'm happy to answer that, or do you guys want to take on a manual pump?
Sure, I'm happy to answer it. So the Haka pump, generally, one of the most important things is for people to understand that it's not actually a pump. It really just uses like negative pressure to just help draw out a bit of milk from the breast, but it doesn't actually pump anything. And so when moms are using it as a pump, that can be a problem. So that's the first thing. But if they're using it properly, there can be certain times that it can be beneficial. So, for example, a breastfeeding mother who's just trying to boost her supply, she can use it on what we call like the third breast. So when the baby has gotten to the second side, the Haka pump can be put on the first side to just help draw out any milk that might be left over to help boost the supply, and then she can go ahead and put it on the other side once the baby's completely finished. It can also be helpful, like a nice gentle way of helping to relieve some engorgement, especially like if the engorgement's like really bad, where pumping can be a bit painful. If you just go straight onto the pump, then using the Haka first to kind of soften the breast a little bit can be helpful. But overall, it really should just be used for that kind of troubleshooting with engorgement, or a little bit of help for a supply when there's not, you don't need like the true power of a pump.
Perfect. Thank you. And I think, it's important, again, although the Haka isn't a true pump, for just manual pumps in general, to recognize that there's a very limited use case for those, really moms who have an established supply, who, just need to very, very intermittently use a pump, are really the only use cases, in my opinion, for a manual pump. Caitlin says, I've heard families swear by handheld vibrating massagers on the breasts and breast therapy hot and cold packs. Do you find these useful?
So it depends what for. The vibrating massagers, what we have heard that they're really good for is if there's a blockage, like a persistent blockage of one of the ducts, then using something that vibrates over the area can help to break it up. I haven't really heard of using it just outside of that in general, but any kind of massage can be quite helpful for the milk supply. And what was the other?
Hot and cold packs?
Hot and cold. So hot and cold can be good as well. I mean, cold especially for engorgement in between pump sessions, and then heat right before pumping, just to help get things flowing. But if someone's very engorged, using just heat can actually make it worse. So you have to know kind of when to use the hot versus the cold.
Perfect. Liza wants to know, how early can you start domperidone?
Typically, we don't start it till about 2 weeks because it usually takes a good 2 weeks to fully establish your milk supply. So there's no point in really starting it too early. Plus, you don't know what your body can do on its own, right? We don't want to start a medication if we don't have to. So we give you at least 2 weeks, 2 to 3 weeks to see, making sure you're pumping frequently. You're pumping the recommended 8 times a day. You're incorporating hand expression. You're incorporating breast massage, and you're doing everything that you can do. And then after that, if you're still not making the volumes that's recommended, then we can discuss the domperidone. But also some moms that started early, it's actually sets yourself up for like engorgement and plugged ducts because you're making more milk too early, sort of thing. So it's important to kind of wait that 2 to 3 weeks to start any medication.
And I think in the majority of cases when moms are asking for domperidone early, when we really look into it, it's really a pumping issue. So again,
Exactly.
you can take all the domperidone you want, but if you're pumping 3 times a day, that's really the root of the problem.
Yeah, and it's hard
Perfect.
because sometimes they think it's some parents want an easy fix, and they think it's
Mhm.
like a miracle drug that, oh, well, I'll just take this medication and I'll only pump twice a day. It doesn't work like that. It has to work in combination with the pumping schedule.
I wish. Yes, that'd be
Yeah,
lovely.
we all wish.
So one last question. So Jen asks, how long do you suggest a mom to pump in the first 24 hours? Usually they say there's no milk.
So that's a really common comment that we get from parents, is that, what's the point? I'm not making any milk. There's nothing there. Let me wait till my milk comes in. So we just had to really educate, like, your milk is not going to come in if you're not doing the stimulation. So from day one, I think Bilal said from 1 to 2 hours after delivery, you need to start pumping or hand expressing every 2 to 3 hours. Because if you don't have that stimulation that we talked about before, your body's not going to know to make the milk.
But I think it's that education though is critical because moms don't know when you're putting a baby to breast. I think a lot of moms assume that in the first day they're actually getting a lot of milk. They're not, but you can't see it. But when you see the lack of milk, it's very disconcerting. So we really have to tell our families that is normal. And I reiterate, the purpose of pumping in the first day is not, for me, is not to make milk. It's not to get milk. It's to tell your body that you need to program the breast. And once parents understand that, I think they get that we're not expecting a lot of milk, and that's okay, and that's normal, and to keep going.
And also just want to add, a lot of moms will say to, or parents will say to us, well, my baby's not eating yet. Why do I need to do this? They think that they can wait 1 or 2 weeks when the baby starts to feed, not knowing that it doesn't work like that. Your milk will be drying up during that time.
That's a great point, Jackie. That's a very, very common misconception that you can wait days or even longer. But again, we really miss that critical window. But we have to educate moms. Like most people don't know, and a lot of healthcare providers actually don't even know. Lovely. Well, I think we'll answer some of these questions in the chat during the next presentation. I'll type some answers, or the LCs can as well. But we're going to move on to our last LC talk, which is lactation practices to improve outcomes.
Welcome to the third and final section of our talk today. In part 3, we will be discussing how to support breastfeeding from day 1 and feeding volumes, especially in those first few days of life. Then oral immune therapy and kangaroo care, both what they are and why they are important. We will also review the importance of non-nutritive sucking in the transition to breastfeeding. A review of how to use nipple shields and some of the instances when they might be helpful will also be discussed. And finally, we will review some reasons for supplementation, breastfeeding aids, and breastfeeding-friendly bottle feeding. We thought that it might be helpful to consolidate our talk about practices that improve outcomes with a baby story. Meet baby Lily. She was born at 32 weeks gestation, admitted to the NICU on day 1 of life, and her mom is still admitted at the maternity hospital. So how can we as breastfeeding support staff help this family begin the journey. In order to support breastfeeding, it is important to, whenever possible, wait for the parent's own milk before offering formula. This is because it provides natural volumes for baby, is nutritionally appropriate, helps to promote the value of human milk as best, shows support for the pumping parent, and helps to promote the transition to breastfeeding. As you have learned from our previous speakers, we often telephone moms while they are still admitted to their maternity wards to give any support we can. This could mean making sure that they have access to a pump and pump kits, as well as all the information they need to begin pumping in hand expression. Lily's mom would like to provide breast milk and then breastfeed her. She is set up with a pump and kits at her maternity hospital, thanks to the postpartum staff, as well as access to the hand expression video, along with some in-person teaching. If supplementation is necessary in those first few days, we should be trying to ensure whenever possible that typical breastfeeding volumes are respected, which, as we know, are very small in the beginning, as only small amounts of colostrum are expected to be produced in the first days of life, and breastfeeding infants drink an average of 15 mils in the first 24 hours and only 1.5 mils of milk per feed. We also know that feeding formula early in hospital is associated with a shorter duration of breastfeeding at home and a lower lifelong EBM dose. When higher volumes are given in those early days, it can undermine breastfeeding, as breast milk volumes are small and increase as the needs of the baby grow. We also know that formula feeds change the gut flora, something to consider when working with babies who are born prematurely. Using donor milk is one strategy employed by many hospitals within ICUs. With parental consent, babies are given donor milk while parents' own milk is being established in those early days of pumping and hand expression. As we know, donor milk is expressed breast milk donated by breastfeeding mothers and is screened and pasteurized for use for our sick and premature babies, as it is the second choice for feeding after mom's own milk. It is important to consider looking at your own institution's feeding protocols to ensure that infants are not given higher volumes of supplementation than is physiologically appropriate during the first week of life. As Lily's mom was pumping regularly and hand expressing, Lily did not need supplementation at this time. However, as we know, this is not always the case. Lily's mom's partner is able to bring the expressed colostrum to our unit. Oral immune therapy is explained to the parents. Oral immune therapy, or OIT, is something that is very important both for the oral experience of the baby and for the introduction of those necessary protective factors in breast milk. We encourage parents to do OIT with their babies, as it is a wonderful time to share a positive experience and allows parents to be involved in the care of their baby right from the start. We use OIT for all babies who are not being fed orally or are being kept NPO for a test or surgery. Fresh milk is always used as we want to ensure absorption of all of those immunity-boosting live cells. It is usually done every 4 hours or after suctioning. Parents collect a small amount of expressed breast milk and take it to their baby's bedside. A mouth sponge or swab is dipped into the milk and then used to gently paint the inside of baby's mouth. A new swab is used with each turn. These pictures show what our bedside OIT EBM looks like. We label it specifically so that both staff and parents know that this milk is for OIT. We also like to use EBM in place of sucrose for painful procedures whenever possible. Some of the benefits to both parent and baby are: benefits for parents are increased bonding, increased involvement in infant's care, and increased rates of breastfeeding. Benefits for baby are helps to boost immune system, oral and sensory stimulation, comfort during painful procedures, feeds begin sooner, babies reach full feed sooner, and has been shown to enhance growth. This video clip demonstrates how it is done.
With freshly expressed breast milk, dip the first swab in the milk, open your baby's mouth, and gently paint the inside of their cheek with the breast milk. Once you have placed the swab into your baby's mouth, do not re-dip the swab into the container of milk. Repeat this process on the other side with the second swab. If you have collected your colostrum in a syringe, simply apply a few drops onto each of the swabs, then paint the inside of the mouth and lips. If your baby is in an isolette and the milk has been refrigerated, dip both swabs into the milk until saturated. Then place both swabs back into the packaging. Place this package of milk-soaked swabs into the isolette for 5 minutes to warm the milk before administering the mouth care. In the case of refrigerated syringed milk, place the syringe in the isolette for 5 minutes before applying the drops on the swabs. Many babies will start to suck on the swab or on their breathing tube during oral immune therapy. This is an expected response and often provides comfort for the baby. Please tell your nurse when you have provided oral immune therapy so that it can be documented in your baby's chart.
And is able to visit. She wants to know when she can hold her baby. Kangaroo care is known by a couple of names. Some call it kangaroo care and others skin to skin. But no matter what your agency chooses to call it, we know that the practice of skin to skin contact is important for both parents and babies. Parents can hold their baby against their chest, skin to skin, as you see in this picture, and use a blanket or wrap to keep baby warm. Most babies can be held skin to skin. However, even for those babies who cannot be held fully skin to skin, there are other ways to offer that close contact with parents. As you can see, there are many benefits for both parents and babies. For parents, things like decreased stress and an increase in bonding, as well as a decrease in the risk of postpartum depression. And for babies, regulation of vital signs, decreased pain during procedures, and of course, it helps to prepare baby for breastfeeding by encouraging positive experiences along with rest and sleep. It is important to facilitate skin-to-skin care with families, along with OIT, as we mentioned, as both are an important part of family-centered care and support family involvement in their baby's care, as well as allowing for those very important times of connecting with their baby during this stressful time of medical interventions and at these times of separation during hospital stays. As we know, this close contact and engagement also supports breast milk production and later feeding.
Holding your baby skin to skin, also known as kangaroo care, is an important practice that is a standard of care for all sick and premature infants. Most commonly, kangaroo care is provided by having a parent hold their baby on their bare chest while the baby wears only a diaper. This skin-to-skin contact is maintained as long as possible while the parent gently holds and bonds with their baby. If a baby's health condition does not allow the parent to hold them on the chest, kangaroo care can still be provided in alternate methods, such as hand hugging, finger holding, and nesting, also known as encircling. No matter how kangaroo care is provided, the key is for parents to have skin-to-skin contact with their baby whenever possible. Kangaroo care is beneficial for the baby and parents. For babies, it can improve their health, not only during hospitalization, but also for long-term development. You can have a positive effect on your baby's health and development by having this contact with your baby. Benefits of daily kangaroo care for babies include positive effect on heart rate, oxygenation, and breathing pattern, stabilizing blood sugar levels and temperature, decreased stress and crying, decreased pain, especially during painful procedures, increased baby's readiness for breastfeeding. Babies who are held skin to skin experience a decreased risk of infection. This is due to the transfer of skin flora during this contact, similar to the transfer of healthy bacteria from mother's skin to babies during breastfeeding. Kangaroo care also encourages deeper sleep, which can help the baby's growth and brain development. All of these benefits are especially important for premature and critically ill babies.
If you have not already, speak with your nurse about which type of kangaroo care is safest and best for your baby at this time. Before holding your baby skin to skin, you and your nurse can help to prepare by performing any necessary care, such as changing your baby's diaper to ensure she is ready for kangaroo care. Your nurse can also help you gather the supplies you may need for your kangaroo care, such as a comfortable chair, a pillow, and a blanket to wrap yourself and baby in. If you prefer a bit more privacy, your nurse can help position screens close by. Before you begin kangaroo care with your baby, it is important for you to use the washroom, eat and drink, wash your hands, and complete any other tasks so you can enjoy being skin to skin with your baby as long as possible without interruption. For mothers who are expressing breast milk, it is ideal to pump before and right after kangaroo care. This will allow you to hold your baby longer and can also help to boost your milk supply. You should wear a top that opens in the front, or your nurse can provide you with a gown to offer your baby the most skin-to-skin contact possible.
If your baby is on ventilation support, it is required that a respiratory therapist or specially trained nurse is also present and assists you prior to the start of your kangaroo care. The respiratory therapist will gather the tubes and the lines to help your nurse transfer your baby to your chest. Once you are seated comfortably, your nurse will transfer your baby to you. The respiratory therapist and nurse will help secure your baby's tubes and lines in a position safe and comfortable for you and your baby. Once the baby has been placed on your chest, the nurse will position your baby so that she is comfortable and can breathe easily during your time skin to skin. It is important to maintain that position. If you need to readjust or notice that your baby has moved out of place, please ask your nurse for assistance. All efforts will be taken to ensure safe holding. Rarely, the breathing tube or lines may become accidentally pulled out or dislodged, requiring immediate attention. If this occurs during your kangaroo care, a nurse and respiratory therapist will help to transfer your baby back to bed and provide appropriate care and support. If at any time you are concerned, do not hesitate to ask for help. For ventilated babies, it is best to keep the number of transfers in and out of their crib to a minimum. We recommend that parents hold their babies for a minimum of 1 hour, but ideally for 2 to 3 hours or longer as tolerated.
Your nurse will continue to monitor your baby during your time skin to skin. However, there are some important observations you can make to help monitor your baby while you are providing kangaroo care. It is helpful to know your baby's regular skin color, breathing pattern, and body language. Occasionally, babies may experience changes in their breathing or heart rate during the transfer or while holding. Should you notice any concerning changes, you may begin by stimulating your baby by gently rubbing their back and calling your nurse for assistance. Now relax and enjoy this special bonding experience with your baby. You may enjoy reading, singing, or speaking to your baby during this calm and relaxing time together. Parents also experience many benefits from kangaroo care. Benefits of kangaroo care for parents include lower risk of postpartum depression, improved milk production, an easier transition to breastfeeding, decreased stress, increased attachment, bonding, and confidence as a parent, feeling part of the healthcare team, and possible earlier discharge from hospital. When it comes time to transfer your baby back to bed, you should inform your nurse who can assist in safely transferring your baby with the respiratory therapist. Since mother's hormones increase during kangaroo care, it is a perfect opportunity to pump breast milk after your baby has gone back to bed.
So kangaroo care is a way for me to contribute to Kara's care. Being in a hospital is very difficult because all of your control is, you don't have any control. It's with the nurses and the doctors, and they're in charge of her, taking care of her. But doing kangaroo care is something that I can do that helps her, it helps me. It certainly helps me when I'm pumping with my milk production, and it just helps me feel like I'm a part of her care.
Mackenzie's 11 days old, and his mom can't be here. So the skin-to-skin contact that Kangaroo Care offered allowed me my moment to bond with him.
For more information about Kangaroo Care, please speak to your nurse or other healthcare provider.
As mentioned, most babies can be
My
held
name is
skin to
Mark
skin.
Frankel.
However, there are times when this is not possible. During these instances, it is still very important for parents to feel connected and involved in the care and comfort of their baby. We use techniques called modified kangaroo care. These involve a number of different ways for parents to experience some skin-to-skin contact with their baby. The first one pictured is finger holding. If babies are too fragile to take out of their isolette or bed, parents can offer their finger for baby to hold. When using hand hugging, parents can use their hands at baby's head and feet to hug them, or use both hands on their body to hug. Encircling is, as you can see in this picture, when parents encircle their baby with their arms to give a hug. Each of these techniques offer the parents and baby the opportunity to connect and converse in a supportive and positive manner. The goal, of course, is to enable full kangaroo care as soon as possible for families, so that both parents and baby can benefit fully from the experience. As Lily is stable, parents can hold their skin to skin and are encouraged to do so at each visit. These are two items that can be used to support kangaroo care. This picture on the left shows one of the wraps that can be used to keep baby close to the parent's body and nicely tucked in and warm. The clip shown in the picture on the right allows for the organization of tubing so that it is out of the way, but also away from the risk of being pulled on or dislodged, which is a great concern for both parents and staff. As team members in the NICU and Level 2 nurseries, it is important to advocate for skin-to-skin practices within our institutions, as it helps to give some semblance of normalcy to the experience, and as mentioned, encourages parental involvement in the care of their baby. Lily spends time skin to skin with both mom and dad in the wrap. It has been 2 weeks since her admission, and Lily is tolerating NG feeds well. She is showing signs of being ready to feed orally. As part of the transition to breastfeeding, non-nutritive sucking, or NNS, is used, as it is a natural transition from kangaroo holding, an opportunity for the infant to become accustomed to the smell and feel of the breast. It's a way for parents to become familiar with baby's feeding cues, and a chance to practice position and latch. It also involves no stress of swallowing or expectations of intake, and has been shown to support longer breastfeeding durations. Generally, NNS is appropriate for any infant who is at least 32 weeks, is having periods of being awake and alert, and is stable with handling. We give parents these recommendations. Pump until no milk comes and then another 1 to 2 minutes. Put baby to the breast immediately. Allow the baby to become comfortable at the breast and experience licking and sniffing. Once the infant latches during NNS, it can be done during the tube feed. And of course, stop if any concerns with baby's condition or many swallows are observed. Lily's mom pumps her breast, and the breastfeeding support team helps mom with position and latching techniques. Lily has some difficulty latching. Nipple shields are one of the tools that can be used to support the transition to breastfeeding. They are soft, thin, flexible silicone coverings that are placed over the parent's nipple with openings at the tip to allow the flow of milk. They're used to support a sustained latch when babies are having difficulties for a variety of reasons. And after a full assessment by a lactation professional, including nutritive sucking ability, shields may be used temporarily for babies who are born prematurely, sleepy, needing time to organize nutritive sucking, or extra or firmer stimulation to elicit the sucking reflex, or having difficulty transitioning from bottle to breastfeeding. They may also be used if the parent has flat or inverted nipples or has an overactive letdown. You will also notice that we have made a comment regarding the use of nipple shields for sore nipples. This is one area that has been debated on and off over the years, and I think the bottom line is that if nipples are sore, our job is to assess what is happening in the baby's mouth to ensure that the sucking pattern is nutritive rather than non-nutritive, which is so often found when moms have sore nipples. A non-nutritive sucking pattern encourages a shallow latch and can damage the nipples. The sucking needs to be transitioned to a nutritive pattern, and once that is established, the soreness should fade over the next couple of days. If we use a nipple shield rather than assessing and helping to resolve the issue, we are not really dealing with the underlying problem and may support its perpetuation, making it necessary for mom to use a nipple shield for the whole time she is breastfeeding. How to use a nipple shield is important to teach parents, as there is a bit of a technique for putting it on, as well as sizing. Gently stretch the shield and invert the nipple portion slightly while placing it over the nipple to help draw the parent's nipple into the shield. Express a few drops of milk into the shield, then bring the baby to the breast while holding the shield in place. Nipple shields are a tool that we can use to assist with latching. However, as we know, when a baby latches onto a breast, the nipple is stretched and lengthened to accommodate the dimensions inside the baby's mouth. As this is not possible with a silicone nipple due to its rigid shape, it is important to use one that is appropriate in size. That means assessing the width of the baby's palate so that when the shield is in the mouth, it is able to fit properly to allow for sucking. Often, nipple shields are sized according to mom's nipple size. However, this can be problematic, as when latched, her nipple, as mentioned, would take on a much longer, more narrow shape to meet the needs of baby. If the shield is too big, because it is sized for the shape and diameter of the mom's nipple before feeding, the baby will only bite it during feeding. This in turn impacts both milk transfer and proper breast stimulation. Shields take some practice to apply, as mentioned. This picture shows how to invert the nipple portion before placing it onto the breast, which helps to create a bit of suction to hold it in place. Wetting the shield also helps to keep it on the breast. As you know, there are a number of different brands of nipple shields. The most commonly used are probably the very thin silicone ones, like this one in the picture. Lily's mom was shown how to use the shield, as Lily continued to have difficulty latching during NNS and is now ready to breastfeed. A 16-millimeter nipple shield helped Lily to latch well with support. Mom was encouraged to use the shield at each breastfeed until reassessed the next day. Mom asked if she needed to continue pumping at each feed. It is important for moms who are using nipple shields and just beginning to introduce breastfeeding to continue pumping after feeds to help protect supply, as at times the shield can dampen nipple stimulation, which can in turn interfere with supply. Lily was able to take half of her feed at the breast. The remainder was given through her NG tube, as she is still getting too tired to finish the whole feed orally at this time. As mentioned earlier, some babies need supplementation. There are a variety of reasons for supplementing babies, both while they are in the hospital and even once they have been discharged. A few might be breast milk supply is low, baby needs extra calories or liquids to gain weight, and baby tires during feeds. It's important to discuss with families the how-tos for each so that parents can decide which method they prefer. How often parents can be at the hospital is also another point to discuss when making supplementation decisions. As is knowing that supplementation can be for a short period of time. However, depending on the reasons and situation, can also continue for many months. These are all important areas for discussion with families when making decisions regarding which breastfeeding aid to use. Lily's mom's milk supply has not increased during this second week. As we know, volume should be at around 700 mils or more per day at this stage. As mom has been pumping regularly right from the start, the LC discusses domperidone and gives mom an information letter to read and discuss with her doctor if she decides that this is something she would like to try. Many of us have probably seen parents using lactation aids in the hospital. The supplement can be put into a syringe or a bottle, and an NG tube is taped to the parent's breast alongside the nipple so that when baby latches, the tube is introduced at the same time. This is one method of supplementing extra volume, but also fortified EBM or formula for babies who need extra calories or EBM volumes do not meet the needs of the baby at this time. Finger feeding is done in much the same way. Baby is in a breastfeeding position, usually football position, and instead of placing the tube on the parent's breast, it is taped to the feeder's index finger or thumb. Supplement is either in a syringe barrel or a bottle, just as with lactation aids. With both methods, it is important to ensure that the bottle or syringe is at the level of the baby's head, as baby needs to drive the feed, just like at the breast. Lily is now much more active at feeding times. She is ready to take her full feeds orally. Lily's parents choose to supplement with bottles, as they feel that it will be easier for others to help with feeding. Mom is taking domperidone and her milk volumes are increasing. However, they have not yet reached Lily's volume needs. The family is also not able to be at the hospital for all feeds, and now that Lily is able to take her feeds orally, they would like her to continue to do so. She will be transferred to a community hospital closer to home this week, and parents will continue to work on breastfeeding with the support of the team there. We hope that putting the strategies to support positive outcomes for babies and families into the story of Lily and her family has been helpful. And that is the close of our presentation for today. Thank you for attending this workshop, and we welcome your questions. These are just some of the resources that are available on the Sick Kids website. And these are the links to some of the hands-free pumping bras. The one at the bottom is for how to make one from a sports bra.
Great. Thanks so much for another great presentation. We've been answering a lot of questions in real time in the Q&A section, so please make sure you go back and read those. There's a lot of really good questions. We probably just have time for one or two now. So we had questions about, I presume this is about nipple shields. If the mom's nipple is large, do you recommend to go by nipple size or baby's mouth? Is there any nipple injury possible if the shield is small compared to the nipple?
Yeah, so as Glynis mentioned in the presentation, it's always important to go with baby's mouth size versus the nipple size. And typically it doesn't damage the mom's nipple because it's such a soft silicone. So the potential of causing nipple traumas, I would say, is very, very low. And sometimes you have those babies that just have a very small mouth and moms have bigger nipples. And it is definitely a challenge for a small population. And unfortunately, there's not a whole lot that we can do. Sometimes it just takes time for that baby to grow, usually about six to 8 weeks. And we usually see an improvement at that point, but it can be a bit tricky in the beginning for sure.
Maybe we can, another question, are lactation aids used in the NICU at Sick Kids?
I'm not sure what lactation aids she's referring to. We definitely use nipple shields. Sorry.
We tend to not use kind of some of the other supplemental
we don't really.
we have an
there's
unusual
supplementing
population.
there's supplementing nursing systems that we definitely do use here, but I would say that we don't use it that often. Obviously we do bottle feeding and finger feeding. We don't do a lot of that here either.
Again, we have a very specialized population of kind of medically complex babies, so we're kind of an unusual NICU in that respect. And then the last question, you say moms need to pump after feeds when using a shield because it can decrease supply. We've been told that research doesn't support this anymore, so only pump if needed. So only pump if supplements are needed after shield use. Thoughts on that, pumping after using a shield?
We typically do still recommend the pumping. I'm not sure what the current research states, just because the nipple shield is still an instrument. Like you still have that barrier between the mom and the baby for skin on skin contact. So babies that use nipple shields, sometimes moms can have a lower supply because they're not draining the breast as adequately versus not using the shield. So, and plus with our population is so high risk, we would usually always recommend, it doesn't have to be a full pumping session, but it can be like a 5-10 minute quick pump session just to ensure the mom's adequately draining the breast, because we don't want to affect her supply while the baby is still kind of learning how to breastfeed with a shield.
Perfect, thank you. I just want to point out too that all the videos that were shown, I put this in the Q&A as well, but the Sick Kids public website, which is about kids' health, has a huge number of lactation videos done by our own LCs that kind of go the range from your preterm infant to pump dependency to going to the breast to troubleshooting. They're available for healthcare providers and for families, and they're excellent. So I really encourage everyone to look at those. And there's also videos on the the premature babies website as well. They're in the Q&A and in the chat as well. Fabiana's posting those, so please check those out. And then finally, we have one last presentation by one of our community lactation nurses about specifics for hand expression as we wrap up this workshop.
Hello everyone, and thank you for joining our workshop. It is lovely to have you all here. My name is Jordan Peck-Doman and I am a registered nurse. I began my career in pediatrics and quickly moved into neonatal intensive care, and now I am working in a small community hospital where my scope has broadened to include both labor and delivery and postpartum. So today I'm going to be speaking to you about ways the nurse can help the mother begin expressing milk early in the postpartum period to improve the chances of developing a good milk supply when they are separated from their babies. Even if you are not a healthcare provider joining us today, these are some tips that you could find useful to know. First thing I want to talk about are some tips for nurses, and I wanted to start by highlighting that education is the most important thing that we can give our patients. Education about expressing breast milk and the importance of this breast milk for the premature baby can start in the labor and delivery phase and should extend well into the postpartum phase. For example, in labor and delivery, if you have a stable patient who has gone into premature labor, has an epidural, and is comfortable, you could start the teaching with them at this point in time. But I know that that doesn't always happen this way, and that sometimes things are really emergent. So if the mother is unwell or unable to be a part of this teaching, we can include the partner or support person in the teaching, and with the patient's permission, start the process of pumping and hand expressing to get that milk flowing through baby as soon as possible. We also know that the first 6 hours postpartum is the most important time to get started expressing milk, and that the colostrum we get is extremely beneficial for the premature baby. It is literally liquid gold, and the mother will actually produce milk that is designed for their baby. I had read a study by Lars et al. That talked about how breast milk is alive and full of healthy microbes and cells that contribute to improving gut health and immunity in the premature infant. This is just one of the reasons why it is so important to get fresh OIT in the NICU. The next thing I want to talk about is pumping and hand expression. Working in the NICU, I found that a lot of mothers in the postpartum period didn't get a lot of teaching about this, or that it wasn't touched on to the extent they had hoped. So I wanted to talk about how using hand expression alongside pumping in the immediate postpartum period, especially those first 3 days, is beneficial for establishing a milk supply and also beneficial for removing that thick colostrum. I want to highlight the importance of pumping first to program and stimulate the breast, followed by hand expression. Even though you might not get a lot of milk pumping at first because that colostrum is so thick, it is still very important to get that programming started and stimulate that breast. Not only will pumping and hand expressing work to stimulate the breast and establish a milk supply, it will also help with the release of oxytocin that in return will help the uterus contract and enable that letdown reflex. We also know that the longer the mother waits to begin expressing milk in the postpartum period, the more difficult it can be to establish a milk supply. That is why I want to highlight again that it is so important to start expressing that milk within the first 6 hours postpartum. There is a little diagram about the steps of hand expression in the bottom corner, but I know it is not the easiest to see, and so I'm going to play you a segment of a video about hand expression by Dr. Jane Morton. This full video can be found on the Stanford Medicine website, and the link for it is listed in my references at the end of the presentation if you would like to view it in its entirety. But for the purpose of this educational workshop, I am going to show you the segment just about hand expression.
Whether your baby is premature or term, here are some steps to help you get started. It is very simple to learn and teach hand expression. In the first couple of days, the average size of a good breastfeeding for a term baby is only a teaspoon. So all we expect to express each session is a few drops to a teaspoon. The more frequently milk is expressed, the sooner milk comes in and the more milk is produced. Partners can help if mothers are too sick. Mothers may find the following suggestions helpful. Have the mother sit up so that gravity is working for her, not against her. Use gentle massage over the breast with hands, a soft baby brush, or a warm towel. It'll help get the milk beginning to flow. Already we can see just with that.
Oh yeah.
That just the massaging. Exactly. That's really good. Place fingers an inch away from the areola, making a C. Band-Aid markers make it easy to remember finger placement. I'm not going to get my fingers down here with a C. I'll keep them here so that the nipple is in the middle of my thumb and my pointing finger. Apply steady pressure inward towards the breasts, never massaging outward towards the nipple or the spoon. So back and then very gently together, and back and very gently together. And I don't expect to see anything in the beginning. So just know that in the very beginning, even when the baby nurses, she doesn't get anything. She's just beginning to sort of stimulate the milk to let down. And then, and the reason I just go very gently is so your breasts get kind of used to it first. And rather than stay on one breast, I go back and forth. So I go from the right to the left, and right to left, and back and forth. When I push back, I don't tighten up the skin, the dark skin. I don't pull like this. I just go straight back and together, and straight back and together. And then we'll get the milk flowing a little bit, and then I'll show you how to do it. And then we might as well start collecting a little bit.
Yeah, sure.
So remember when you try to do this yourself, that in the beginning, the milk didn't come very easily. And now it's coming very easily. Think of press, compress, relax. Press, compress, relax.
The last thing I want to talk about is some tips for mothers with premature babies, whether that be in the postpartum period or the NICU period. One of those tips is to pump and hand express at night. The body produces that good milk-making prolactin hormone, and it is highest at nighttime. So when the mother pumps at night or is using hand expression alongside pumping, they will notice that there is an increase in the milk production. Another point is to start a pumping log as soon as possible. This way they can track their pumping times and volumes, and it can help keep them on a schedule. But it can also show what their volumes are compared to what their baby is eating, and sometimes that is a good goal for moms. Also, another thing to really highlight with them is to not be afraid of doing some massage. There are milk ducts that extend to the outer breast, and by massaging those milk ducts, especially in the postpartum phase when that colostrum is really thick, it can help to loosen things up and get that milk moving. Even when you're not hand expressing anymore and you're just pumping, this can be helpful to get that milk flowing. Finally, pumping after kangaroo care or skin to skin is a really great thing. We know that oxytocin is released when mothers have snuggles with their babies, and that can really help to improve overall milk production and volumes. For us nurses in the NICU, we should be encouraging kangaroo care and skin to skin whenever it is clinically possible. There is just so many great benefits that we cannot ignore. And a lot of these moms will have babies skin to skin, and they will already be expressing milk just by having their baby on them. So this finally wraps up my tips for nurses to help mothers with expressing milk. I hope you will be able to use some of these points alongside your current practice to help mothers in establishing their milk supply. Thank you for listening in.
All right, and thanks so much to Jordan, who actually couldn't be here, but it looks like we're actually running out of time. So I want to thank everyone for your attention. I want to thank all of our amazing panelists today who gave their time to put together these really good evidence-based talks. And I hope everyone in the audience was able to take different pieces away that will hopefully help provide excellent care to all their lactating families to meet, again, whatever their lactation goals are. So thank you again to Fabiana, to CPBF, and to you for your attention. And I hope just to leave you with making sure that you are establishing lactation early, often, and effectively, and really providing early education to our families. So thank you again. Stay well.
Thank you, Dr. Hoban, for creating this workshop. I think we all learned so much from you, and all the presenters was great. I also want to thank each and every one of you for sharing your vision of a brighter future to all premature babies and their families. I'm very grateful that you have a big audience from across the world today. I obviously want to thank our speakers, great presentations, and a special thanks to the Sinai team, Jacqueline and Evita, for supporting us with all the logistics. It was a lot of organization behind the scenes. And obviously I want to thank our sponsors, Medela Canada and Prolacta, for their ongoing support to our education sessions. So I do hope you all have gained extra knowledge and many insights. And please do fill out our survey. We'll be sending it to you after this webinar. And our website is right there, thecanadianpreemies.org. We offer support for families and education, all for free. Please follow us on social media to learn about future events and our current programs for families. We will repeat this workshop again on November 4th. Please share the website with your colleagues. Registration is still open. We will send the recordings after November 15th to all of you who attended this workshop today. So make sure you receive our emails. Is the info@cpbf.fbpc.org. So make sure it's not on your junk box. So thank you everyone, and stay well.
Everyone, thank you.